evening. And yesterday we had a great session, and we had focused more on precision PCI with imaging and physiology. And there were wonderful talks, very interactive. Today we hope and we wish that it will be the same, and we have a wonderful list of speakers and good topics which should have a lot of clinical relevance also. So we'll start today's session. With me is Dr. Mahesh Kasarge. I'm Dr. Parvinder Singh. We are both cardiologists at Baroda Heart Institute and Tricolor Hospitals, Baroda. And we'll go to our first talk, and that's by Dr. Praveen Chandra. And it's an honor to introduce Dr. Praveen Chandra. He is a Padma Shri. He was awarded Padma Shri. He's a chairman and HOD of Interventional Cardiology and Structural Heart Program at Danta Hospital, Delhi. He's been an author and reviewer to numerous national and international articles and journals. He has also been a major faculty at various international conferences and workshops. He's one of the leading cardiologists in the country. He's proficient in the use of new devices and technologies and has been the first to use multiple devices and treatment modalities in the country a number of times. He's a key organizer and director of the very popular AMI courses, which many of us have attended and have had a great experience. So I welcome Dr. Praveen Chandra to give his talk. The topic is evidence-based treatment of ACS patients.
Yes, Dr. Praveen, we can start. Praveen, you have to unmute your mic.
Yeah, I have done it. Okay, thank you.
Yeah, okay, thanks. So, good. Let's start.
Thanks a lot for this, evening program organized by Dr. Parvinder and Dr. Mahesh and their group from Baroda. And I can see a lot of very experienced people sitting on the panel. So I'm glad to share all these slides with you. And of course, I'll have some time for discussion as well. So, evidence-based treatment of ACS patient, and let me just tell you, so I'm basically will be touching upon the interventional aspect of ACS intervention or ACS treatment. I'm not covering the whole subject of ACS today because I understand that it is primarily meant for interventions, and of course I'll go through that. So why it is not moving? The slide is not moving. Panel. Okay. So as we all know that in acute coronary syndrome, the issues are that when these patients come to us, of course, there is a culprit lesion, but there are non-culprit lesions also. And that is one of the very common issues when we are treating acute MI or ACS patients. What to do with those other lesions? What is the evidence behind that? How do we make patients safe as possible? So we will go into that because that primarily is directed towards incidence of heart failure, recurrence of symptoms, and of course also ultimately survival of these patients. So what was the guideline saying? So 2017 AMI guidelines said that for non-IRA lesions, routine revascularization of non-IRA lesions should be considered in STEMI patients with multivessel disease before hospital discharge. And non-IRA PCI during index procedure should be considered in patients with cardiogenic shock. So that was the recommendation. But now we have more information and, for the stenosis, which is intermediate or in other vessels, which is very difficult to assess sometimes in ACS patients. So FFR assessment of these arteries is another way of going about it. And in these patients, if you look at this posted study, it shows that if you do FFR in these patients to the non-culprit vessels, then the outcome changes. So here you can see that if you go the conventional way, the pre-FFR way, about 360 patients in this, as you can see, were going for medical therapy and 319 for PCI. But in post-FFR situation, you see that large number of patients can safely go for medical therapy, 438 compared to 360. And PCI also increases, but certainly those patients who are in limbo, that means those patients who potentially need therapy will be treated beforehand and will most likely prevent events in the future. And then the next question comes is how stable is the FFR in non-culprit vessels in ACS situation. So the studies are available which show that if you do FFR in acute situation and then you do again FFR in follow-up situation, the values don't change. So that is why it is reasonable to do FFR to these non-culprit vessels during acute phase of ACS. So it is feasible to make functional decision about the need for additional revascularization in ACS patients, which may change treatment decision for these patients. So that makes things a little simpler if we do this. And this is the compare acute study, which is the biggest study available now for FFR guided complete revascularization in patients with acute coronary syndrome. And as you can see here, FFR guided complete revascularization is much more effective than infarct only strategy, and then making other decisions based on the assessment of ischemia later on. So the cost factor is also not high, and it is found to be cost effective strategy if we therapy where FFR guided intervention is done. So in multivessel disease, I think after this compare acute study, it is a reasonable idea. And before that, we already had the Dynami study, and there were a number of patients who were treated in this strategy where FFR was done to the multivessel disease patients, either during the index procedure or during index hospitalization. So both have been studied. Now, the second thing is about what kind of stents do we choose in these kind of patients to improve outcomes, because these are special cohort of patients where there is a lesion plus there is a thrombus. So we need to have a stent where the thrombogeneticity is minimum and the inflammation is also minimum. So is there any data on this? So these are the bedside data from the various devices, various stents. As you can see here, these are the photomicrographs of these stents showing the platelet deposition on various stents. And as you can see here, the Biomatrix, the Synergy or Zero, these are the new stents which we are using every day. The Nabori stent, the Zynes, the Ultimaster stents, and we can clearly see that there is a difference between various stents in terms of platelet deposition. And also the fluoropolymer durability at the end of 42 days, if you see the comparison in the biodegradable polymer, initially we thought that biodegradable polymer will be a better idea, but ultimately now we have so much information saying that biodegradable polymer may not be the best thing to do in acute MI or ACS situations, because that was a concept we started having when initially we had the data from many studies showing that the biodegradable polymer may be a good idea in ACS and acute MI, but not it did not show much results in that. Then the safety of this polymer, this EES fluoropolymer in particular, if we now compare the biostable polymers, again shows that this polymer has less inflammatory response. And these are the data from cases. These are autopsy studies where initial suppression, healing, and inflammation was studied, showing that the inflammation is much lesser. And in terms of clinical outcomes, if you look at this, compared to the other first generation stents, the safety and efficacy at 7 years has been quite improved when Zyne stents were compared to these stents. Then the all-STEMI examination trial, this Zyne shows lower long-term stent thrombosis rates versus bare metal stents. So clearly, initial idea of bare metal stent is almost gone. So I don't think any lab today uses bare metal stents for even acute MI situations. So that has been already established. So whichever type of drug-eluting stent you are using, it is better than a bare metal stent in patients with acute MI and ACS. Then, of course, in terms of stent thrombosis, again, did not the DES, the Zyne stents showed that they were better than BMS and also better than other DES compared to in terms of stent thrombosis and ST elevation MI. Vascular healing again, starts as early as 2 weeks, based from this data in terms of measuring the uncovered struts, percent uncovered struts and the maximum area of thrombus. So both you can see there is a significant difference in the uncovered struts, very few at 2 weeks in these two situations. Then vascular healing in stable angina patients also we have that, you can see that the uncovered struts are very, very few at 1 month and 3 months when Zine stents were used in these studies. And of course, this is a OCT guided study because you can't see unless until you do OCT in these patients. Then the third thing is, the use of DAPT in patients with ACS undergoing intervention. And the guidelines were that, you have to use it for 1 year. But now more expansion is happening. And of course, there are many patients who are also having bleeding risks. So if you look at this, the stop-tap trial, which demonstrated 0% stent thrombosis with Zine stents at 3 months tapped. So that was the first indicator which started coming in 2015. And now much more information has accumulated with more than thousands of patients where 1 month tapped was given to these patients. And of course, more and more information is also going to accumulate, especially in different subsets of ACS and acute MI, where short DAPT can also be given to these patients who already have DES in patients with ACS and AMI. Now, the last thing is about the preparation of these vessels which are undergoing ACS and MI, how we make it safer, how we make it better. So what are the optimizing strategies? And if we look at the data, which comes for the reasons of stent thrombosis in these patients, and you look at this, the most common cause is uncovered stent struts. The second is, of course, malopposition, and then the edge dissections are actually the least. And you can see the edge segment disease, stent overlap, stent fractures, of course, are the minimum, but the maximum is uncovered and malopposition of these stents, leading to acute, subacute, and late stent thrombosis. So this is the OCT information which was collected, and it gives us a lot of understanding on the underlying stent thrombosis mechanism from these registries, especially the PESTO registry. A mechanical abnormality in the vast majority of these cases where stent thrombosis actually happened. So in this, OCT plays a very, very, very big role. And so that is how, it starts establishing the role of doing imaging with OCT in these patients. And if you do OCT guided treatment strategy in ACS patients, then almost 38% lesions were actually deferred. The stenting was done on only 62%. And because these patients, many sometimes had just large thrombus burden, and then there was no need to do stenting in these cases. Just medical therapy was good enough. There were no cases of sudden death or MI at minimum 12 months follow-up in those patients where the lesion was deferred. So stenting can be, kind of controlled if we use imaging in these patients. And this is the results of the erosion study to establish, distinguish the plaque, recognize thrombus, and optimize ACS treatment strategy. So with this, in 1/4 of patients, it distinguished the nature of plaque, and the erosion of the plaque was the commonest abnormality which was seen here. And many times conservative treatment again showed that with antithrombotic therapy without stenting, this could be an option in many such patients. And this is, the use of OCT, which can make a difference post-stenting also. And this reflected in the outcomes in terms of FFR outcomes in the non-ST elevation ACS cohort of patients. So basically, if we combine these technologies of imaging and physiology, it might lead to better. Now, this is the data from Illumine 3, which confirms that OCT is superior to IVUS in detecting certain predictors of major events. And here you can see that the major dissections, there was 50% reduction in major dissection if OCT was used compared to intravascular ultrasound. And major malopposition was also 50% reduced. So the outcomes changed because of the use of imaging in these studies. So now basically to optimize the PCI outcomes in ACS patients, The role of the stent is important, definitely, as you saw. And we have to use DES, which is considered gold standard for STEMI patients or ACS patients, because there is a difference between biopolymer, biodegradable polymer, and biostable polymer. There is a difference between in the material also, in the platform also, and the studies which I already showed you, these meta-analysis, they show significant reduction in stent thrombosis and TVR at long-term follow when Zymes was compared to first generation DS. Role of FFR, I think, is fairly well established now, and FFR guided complete revascularization led to a 65% release compared to infarct-related artery treatment alone. So FFR can reliably assess non-culprit related artery lesion severity, so it is a good idea to have do FFR in multivessel disease patients during ACS. And of course, use of OCT during PCI might make a major change in your thinking and your approach, and it can lead to a better treatment strategy for ACS, where stents can be avoided, where conservative therapy alone can benefit a reasonable number of these patients. So with this, I think I'll stop here. Thank you very much for your kind attention.
Thank you, Dr. Praveen.
Thank you. Thank you.
Welcome.
Yeah. Thank you very much, Dr. Praveen Chandra. It was an excellent talk and it was good insight. And it also shows that how important it is to have FFR and OCT in probably every lab. And probably in the future that should happen. And as the cost of the equipment and the catheters would go down, probably this is what is essential for each and every cat in the country. At this point, I'll just take the opportunity to welcome our panelists, Dr. Bhupesh Shah, Dr. Dharmesh Solanki, Dr. Girish Kautekar, Dr. Suhas Lele, Dr. Prakash Veer Parikh, Dr. Krishnanand Pai, and Dr. Varun Siddal, and Dr. V.C. Chauhan.
If you have one or two questions, we can have to Dr. Praveen, because it will be good to interact with him.
Dr. Praveen, what is the choice of antiplatelet? I mean, you are preferring at present Prasugrel or Ticagrel for ACS patients?
Okay. Yeah, so that's a very good question. I think today, if there is no contraindication to Prasugrel in patient undergoing acute MI or ACS, I generally prefer Prasugrel because number one, Prasugrel is cheaper compared to Ticagrelor and has great efficacy in these patients. And it's just once a day dosage, no side effect of breathlessness. The second is Ticagrelor. We use very commonly in these patients if there is no increased high risk of bleeding. And the third is Clopidogrel. So Clopidogrel we generally preserve for non-ACS patients and also those patients where the risk of bleeding is higher than normal, there we use Clopidogrel. I hope my other panelists agree with this approach, or if somebody has any other idea.
Dr. Irevat,
we agree, but for your patient, cost is not the issue, Praveen Chandra. That is only the concern.
This is a very interesting thing, Everybody feels that only the risk
We feel that there is no cost issue.
No. I think cost is a concern nationwide. It's a nationwide problem. And I am part of India.
No, I would give the cost difference between Prasugrel and Ticagrel now is getting smaller and smaller. So,
yeah.
Though Ticagrel has the bleeding as a possibility issue, I would still feel that it has a better safety data compared to Prasugrel. I generally prefer using Ticagrel compared to Prasugrel for AMI situation. I think efficacy-wise, both appear pretty similar. And the advantage of Prasugrel is even if patient forgets, the action is quite long. So it goes on for 4 or 5 days. So even if your patient forgets 1 or 2 tablets, they will be while with Ticagrel, since the duration is quite short, half-life, I think your patient must be very, very reliable in taking the tablet.
Absolutely.
Doing FFR on the non-culprit vessel for that matter. I mean, I would always do it like you fix the culprit. At the end of it, you do an FFR on the non-culprit vessel. But then I always repeat it when I bring them back. If FFR is positive, if FFR is negative, you're not going to bring it back. If FFR is positive, you bring them back. But then I repeat because microcirculation has a lot to do with what the FFR shows. So during acute phase, whatever FFR you measure might change a little bit, though you showed one slide where FFR during acute phase and done later did not show much difference. I, for one, would feel that microcirculation does make a impact, and the microcirculation is all constricted.
Right. So, that's what we feel. But the data which we have as of now shows that in the non-culprit vessel, if it is truly a non-culprit vessel, then it should not change. And so, if you are taking a decision, so I think this strategy is also reasonable that you can repeat it again. And of course, if you can have data, this is our Indian patient, so this will be very interesting. Yeah.
And Hiramat and Dr. Chandra, do you think in culprit vessel after 5 days FFR can be valid if patient has come late and there's a borderline FFR is positive after 5 to 7 days? Would you rely on FFR?
So,
Yes.
Dr. Hiramat, yeah.
Yeah. I mean, but why would you do it on day 5?
No, we get some patient who comes late. Some people are thrombolyzed, or they come after a few days, and then we have to consider whether to touch these patients or not.
No. You are talking of the culprit or the non-culprit?
No, first 5 days culprit is not reliable. FFR is unreliable culprit, but I'm talking of after 5 days. So it's a semi-acute situation where FFR may be reliable.
John, patient had an MI, say, from LAD. Now he has come to you after 7 days. The artery is swollen and there is a borderline lesion.
Yes.
Well, I think FFR in the culprit vessel, because there is a lot of the main vessel may look borderline, but the microcirculation is all clogged up. So I would not rely too much on that FFR, on culprit.
So I think, so that will be a mixed approach in this kind of situation. As I was showing the data of OCT, so these kind of patients, you have to look at the plaque itself, because many times these are thrombus containing plaques. At some points in time, these are plaque erosions, and there are certain where you see a haziness, but you are not very sure whether you put a stent or not.
Yes.
So combining and doing FFR is fairly reasonable in these cases also, which come after 5 days, because here the interplay is happening of three things. One, how much infarct has already happened. So if the artery is already infarcted and the territory is already infarcted and the lesion is not looking critical, or even if it is looking critical, you can do a FFR, because the infarcted segment also has a big role to play in determining the values of FFR. So that is why I will say doing FFR is reasonable if you are doing it after 4 to 5 days. It's okay.
Exactly.
I mean, you're obviously differentiated between plaque erosion on one side and plaque rupture on one side. Erosion does not need a stent, but rupture needs a stent, even if the lesion is not critical. So I think FFR, you may do it, but the interpretation should be done with some kind of wisdom, that this is an acute situation and this is the FFR, whether you value it or would you like to do an OCT to see if there is erosion or rupture. If FFR is negative and yet you have a ruptured plaque, I think a stent is still indicated. So I would probably skip doing FFR in this situation and rely more on OCT.
We know that OCT is going to help us a lot in this situation in acute MI when the ACS conditions that there are spasms and we are relieving with the nitrates and in everything. But if for the Indian scenario, OCT is not available, what precautions, particularly in ACS conditions, you would like to guide the operators? We are using sometimes, not all the patients because all are not very affording, in how to prevent or what extra precautions should we take. As one dictum was that 1.1 or 1.25 the size of the you dilated, you will be relatively sure. The stent boosting boost and everything can help. Anything else you would like to guide?
You are basically talking of avoiding the distal embolization, correct?
No, I'm talking of the avoiding malapposition by doing the OCT post procedure.
I think I would still use the reasonably high pressure, even if it is an acute situation. The higher pressure that you use, the chance of distal embolization is much more. So pre-dilatation would be with the smallest balloon. So wherever possible, you bring in a stent early and go slow on inflation so that you allow these stent edges to flare first. Might constrain the thrombus at the local site where stent is deployed. I think this is the way you may try, but it's not sort of a full. Once you post dilate, I think some thrombus will come in between, which is trapped between stent and the wall will always come out in the women.
I agree with Dr. Hirmat that this is a very good strategy. And there are two other things which I do in these patients is that if the blood pressure is permitting, then I give them a load of nitroglycerin and diltiazem so that we adequately vasodilate these vessels, because as he was already saying that these vessels are slightly vasoconstricted. So dilate them so that then you will know the exact size of these vessels, and then you can really size the stent well to the 1:1 sizing to these vessels. And the second is
This is
in
very
those
important.
patients,
Rohit,
where
just
there
add
is
here.
yeah,
If you find a vessel totally occluded, do a dilatation with the small balloon, establish little flow, and that's the time you start injecting all these dilators. There are times where you fail to establish a forward flow with the balloon. So there are times when we go with the microcatheter deep down into the vessel and give these dilators intralesionally because otherwise the material will not reach distal. So these are the ways you dilate the microcircuit. Okay, back to Praveen.
Yeah, and the other group of patients is that those patients who are on inotropes. Now, especially if they're on slightly higher dose of inotropes, what inotropes do is that they constrict the vessels.
Yes.
And then what you are seeing is the whole vessel is constricted, and one feels that the vessel size LED is looking like a 2.5, 2.75, and actually is a 3.5 vessel. So again, in these patients, giving local vasodilatation is not a bad idea. Please do that, because otherwise you are putting a stent in a vasoconstricted artery, and that this should be remembered in those patients where these patients are on inotropic support, because they have a systemic vasoconstriction.
But Girish, when you do primary angioplasty, at least I don't go to the pressures that we use for chronic stable angina. I'm a little bit less, about 10, 15% less. Though, of course, stent apposition with the vessel wall is very, very important. So I might oversize the stent a bit and deploy it at a usual pressure like 12 or so.
That's what point was that whenever we are really going for the ACS, normally 1.1 or 1.2, because still because they are on inotropes. They're acute angio, they're normally for the all the anesthetists, at least in are this thing, he starts with it because his safety, our safety, everybody is comfortable with that pressures being high. So one point was that yes, minimum handling with the thrombus and direct stenting with minimum small balloon. And second is that we have seen it so many times whenever we do the recheck angios, our size of the is equal or bit smaller. So the vasoconstriction, even if we give the local vasodilators, the inotropes and acute MI per se, can produce the vasoconstriction of the vessel. So we are, I was discussing the point 1.1, 1.25 is normal. Younger patients, we are going bit higher, and older you can have to 1:1. I don't know what is the panel thinking of it, but 1.25 in the younger and 1.2 and 1.1 are equal in the older patients, not to really chase these guys. So
I mean, I wouldn't generalize like this, but probably you and I are thinking pretty close to each other.
yeah, we don't
I also believe that
decision on this
these
paper.
are reasonable strategies.
Yeah, reasonable.
Yes. Thank you very much, Dr. Praveen Chandra. This is an excellent
Thank
discussion,
you.
very informative. And it also shows that how individual patients need to be customized as we are treating. And based on what we find, the decisions probably can keep changing with time. We'll go on to the next talk. That's by Dr. Krishnakant Sharma. His topic is my approach to ACS patients. He's an interventional cardiologist at Baroda Heart and Tricolour Hospitals, Baroda. He's a very bright and enterprising young cardiologist. So I invite Dr. Krishnakant Sharma to voice talk.
Yeah, I'm audible now.
Yeah.
Okay. Good evening to everybody. There are lots of seniors are there. To all, thank you for this opportunity to give a talk here. And approach to acute coronary syndrome. I have a very short notice for this lecture. Otherwise, I will keep us some cases and we have interact more. But now we go with some basics and we'll discuss the topics which are some having confusion or have some interaction in that medical therapy. So it's a completely non-interventional talk. Let's go. We know slide is not moving. Yeah. So we know that acute coronary syndrome is having unstable angina, non-acetylene aspiration MI, and chest pain is the critical feature is there. Unstable angina is due to non-occlusive thrombus with non-specific ECG changes and normal cardiac enzyme, and the ST elevation MI is with non-occlusive thrombus with some ST depression, T-wave changes, and elevated cardiac enzyme. And ST elevation is because of the acute plate rupture and complete occlusion. Epidemiology and the problem magnitude, if a GRACE study will see, after the index event of 1 in 5 patients of SS will die. And remember, the ST elevation MI mortality risk is same as like non-ST elevation MI, so we have to treat aggressively both these categories. And after the index event, at the age of 60 years, if we compare the life expectancy, the life expectancy is very much decreased, especially of females patients we have. At the graph is showing at the age of 60 years, the reduction in mortality is 12 years and 9 years for male, and respectively 50, 70, 80 years, the males having 12, 6, and 4 years. However, the females is having more life expectancy reductions. Females are more late presenter, complicated, have poor prognosis, likely to die. Indian magnitude, we know that young kids presentation more complicated. They have peripherally received thrombolysis or too many drugs and then come to us. So they're confusing how to load, how to treat, and 30 days mortality is again high. Nowadays, what happens that the WhatsApp is available and what your emergency physician is not keen to do the thorough physical examination and send to ECGU, and patient have chest pain and tell you to do what to do next. So remember, again, your emergency physician is capable of exploring the chest pain in a non-ischemic categories also. So sometimes what happened, we have taken the patient in cath lab and then find out that there is some aortic dissection is there or pulmonary thromboembolism there. So the high likelihood of CAD is there in ACS patients. So we have to do a thorough history at the point of first contact, then examination, ECG, and doing fast cardiomarkers and echocardiography. We have to also keep in mind the non-ischemic causes of elevated troponin, which are congestive heart failure. And nowadays, COVID-19 is the situation where troponin is elevated, patient presented with chest pain, and then we go for HRCT and found the ground glass opacities. Once the patient of ACS came in emergency, we have to find out the high-risk features in that. If patient is having repeated prolonged chest pain and discomfort with elevated cardiomarkers, dynamic and persistent changes with transient ST elevation, hemodynamic instability, and sustained ventricular tachycardia or a syncope episode with LVEF is around less than 40, and prior PCI within 6 months and presence of typical symptoms with diabetes and CKD, we have to manage for an early invasive strategy if all our things are going fine. We have to risk stratify. This is again, we all know this TIMI-risk score, we can use that. And we also know that we have to prefer the PTCA over and above the fibrinolytics when the fibrinolytic therapy is contraindicated, patient having cardiogenic shock. And when uncertain diagnosis taken on cardiac cath and revealed coronary occlusion, we have to do PTCA. And there are some situations where PTCA is preferable to the fibrinolytic therapy, like elderly patients, hemodynamic unstable patients who are having prior CABG, large entry infarction, and patients with old MI. Even after fibrinolytic therapy, if high-risk features are there, we have to shift the patient to the PCI-capable facilities as early as possible. If there is a CLIP class 2, previous MI, new onset extensive MI, systolic blood pressure is less than 100, heart rate more, and right ventricular involvement with inferior wall MI. Now the topics comes which are having some interactive values, like now ACS patient comes to you, what is your choice of antiplatelet therapy? So first thing, we use aspirin, which is uncoated. You should be used up to 350 milligram and should be chewed and crushed to given to the patient. The second drug would be a P2Y12 inhibitor therapy. And if your patient comes directly to you and you are about to take for the angiography, then Ticagrel 180 milligram or a Prasugrel 60 milligram would you can wait for Prasugrel. When you know the coronary anatomy, you can load with Prasugrel. If you are taking within 3 hours to the cardiac cath, you can wait for a second loading dose, second antiplatelet agent. Otherwise, you can use Ticagrel 180 milligram because they are both are superior potent antiplatelet. They're good bioavailability and good platelet inhibition compared to the clopidogrel in all studies. So Ticagrel and Prasugrel are preferable to the clopidogrel. When the patient come to you and there is already high bleeding risk, like CKD or earlier history of GI bleed, then you can choose clopidogrel. So there are very limited indication of clopidogrel nowadays. Otherwise, you have to go with Ticagrel and Prasugrel. Even those patients who have received the thrombolytic therapy, the TREAT study is comparing the Ticagrel, which is administered, loaded within the 24 hours of fibrinolytic therapy, and they compared with the clopidogrel and Ticagrel for the major bleeding. And if you see the TIMI major bleeding, plateau major bleeding, and the bleeding academic research consortium criteria of type 1, 2, 3, 5, and 3 and 5 are major bleeding, then Ticagrel is even non-inferior to the clopidogrel even after the fibrinolytic therapy is received by the patient. If it is loaded within 4 hours of fibrinolysis, then only the TIMI major bleeding is more, otherwise all are comparable with the clopidogrel. So after the fibrinolysis therapy, Ticagrel can be used as an antiplatelet agent and taken for early invasive strategy. A topic about the Prasugrel versus Ticagrel. The only one study, that is ISHAR REACT 5 open label trial, which studied the 4,000 round of patients. And before the randomization, patient is given Ticagrel and Prasugrel, and the procedure is done within 6 to 61 minutes respectively. And this is the only study where the primary endpoints are not favorable for Ticagrel use or statistically significant good outcome favoring the Prasugrel use. And the major bleeding defined as the BARC type 3, 4, and 5, they occurred similar frequency in both groups. However, this trial is an open label study, and there is a population which is included is only of 5 centers in the Germany and European countries. So until the further evidence is available of the superiority of Prasugrel, the Ticagrel and Prasugrel are comparable and used equally according to the patient profile. What to do with GP2B3A inhibitor therapy? Routine use is not recommended, but however, if your NST elevation MI or ACS patient is having high risk features and you are about to take in a cath lab, you can start on GP2B3 inhibitor infusions. However, they have received adequate dual antiplatelet therapy. If there is persistent chest pain and ECG changes, you can start on GP2B3 inhibitor before the procedure. Otherwise, GP2B3 inhibitor blockage is indicated in high-risk patients who have large thrombus burden on angiography table or as a bailout of intraprocedural thrombotic complications only. Even if they have received adequately before the procedure with Prasugrel or Ticagrel, then again, your GP2B3 use should be cautious because there is a high bleeding risk with Prasugrel and Ticagrel. The studies of routine use like ISAR-2 acuity timing trial and early ACS trial, those who have used abciximab, eptifibatide, and tirofiban had shown in a routine use significantly higher rate of bleeding and PCV transfusion later on in the patients. ACS patients you have taken for angiography and now need for early CABG, then we have to discontinue the antiplatelet therapy. So it's 5 days for Ticagrel and clopidogrel and at least 7 days for Prasugrel because it's too potent. But some evidence suggests that due to reversible inhibition, Ticagrel may be discontinued within 3 days before the surgery as a reasonable strategy. If you stop your antiplatelet therapy and you kept on infusion of GP2B3 inhibitors, then for eptifibatide and tirofiban, it should be 2 to 4 hours before the surgery, you can stop that. And for abciximab, at least 12 hours before you have to stop your antiplatelet infusion. So precautions. Ticagrel have an adverse event of bradycardia and breathlessness, as we know, so should be avoided in patient at risk of symptomatic bradycardia, including those who having second or third degree of atrioventricular block on ECG. Ticagrel can be avoided, and patient with co-administration with strong CYP3A4 inhibitors like ketoconazole or clarithromycin, they can have an increased Ticagrel exposure and increases the bleeding risk. As we know, with Prasugrel, there is a black box warning. We have to use within the 75 years of age, more than 60 kg of weight, and it should be loaded in the 60 milligram dose and 10 milligram to be maintenance dose. But in the Cardiology trial, we can use 5 milligram per day in patients who are having more than 75 years of age or who having a weight less than 60 kg. Prasugrel pre-treatment before knowing the coronary anatomy is not recommended. Whatever the best trial for Prasugrel is Trinitron TIMI 38 trial, which has established the superiority of Prasugrel over the clopidogrel. In that trial, the Prasugrel is given after the angiography only. The ECOS trial, which evaluated the effect of Prasugrel pre-treatment, they have randomized the patient given 30 milligram before the procedure, 30 milligram at the time of procedure, and then the maintenance doses. But in this study, again, the rate of key safety endpoints like TIMI major bleeding episodes were greater with pre-treatment. So till now, the further studies, Prasugrel pre-treatments are not recommended. Dose of antiplatelet therapy, particularly clopidogrel. In our practice, we generally use 75 milligram BD after the procedure if suspected some complex procedure or 2 stents, however, type A lesions. We can use, we also routinely use 70 milligram BD doses. However, the clopidogrel 75 OD doses are recommended as a maintenance doses. The trial which favoring this dose regimen is the current OSS 7 trial, which used the clopidogrel 600 milligram followed by 150 milligram for 6 days. And another randomization is for clopidogrel 300 and 70 milligram OD days. But in 150 milligram daily for 6 days, group is having a major bleeding complications and comparable good significant reduction in the secondary outcome and stent thrombosis. However, due to bleeding risk, the higher doses of clopidogrel is not recommended. Once your ACS patient has need of anticoagulants, there are 2 types of anticoagulants needs in ACS patients. Once those who are having AF and have needed of chronic oral anticoagulation therapy, and those patients who are like having prosthetic heart valves and or already on anticoagulation. So these one subset of patient, and another subset of patients, those who need anticoagulant therapy due to ectatic vessels with a high thrombotic burden or a LV clot. So in these types of patients, you have to first identify your patient in what category. It is in high bleeding risk category with a high thrombotic risk, or it's a low bleeding risk or low thrombotic risk. So according to that, if we divide that patient's category, we can choose our antiplatelet therapy. You usually use Novec plus clopidogrel if patient is having already AF. We can add aspirin if we have done procedure to prevent the stent thrombosis for 1 month, 7 days, or 6 months, depending on the bleeding risk profile. We generally use heparin in ACS patients compared with enoxaparin because we can reverse it, we can monitor it comparing to the enoxaparin. However, the enoxaparin and heparin give same primary good endpoint profile. So thank you so much. This is all about the non-interventional aspect of ACS.
Thank you, Dr. Krishnakant. I think Dr. Robert has some difficulty in logging in. So we'll go to next talk by Dr. Prashant Jagtap. Dr. Krishnakant, you can stop sharing your slides.
Yeah, I'm doing that one.
Yeah.
Yeah.
Dr. Prashant, are you there?
Yeah. Hi, good evening to you all.
Good evening, yeah. So Dr. Prashant Jagtap is, needs no introduction. Naturally, he's a good friend of us. He's one of the senior interventional cardiologists in Maharashtra and very well known in the country. He's director of interventional cardiologist in newly promoted his own Viveka Hospital in Nagpur. So Prashant, welcome, and we can start your talk.
Well, good evening to all of you, and thanks Parvinder and Mahesh for giving me this opportunity. I would like to speak on this topic on high bleeding risk patients. I think it has achieved great importance in today's practice. We have a lot of elderly patients. We have a lot of patients on oral anticoagulants because of atrial fibrillation, and with the diabetes, so many CKD patients. So I think very, very important topic, and a lot of work also on high bleeding risk patients in the last 2 years. So that is the reason why I have selected this topic. And now, what are the challenges? If you really look at the high bleeding risk patients, the relevant clinical data is very deficient, because most of the clinical trials, they have excluded the CKD patients, they have excluded stroke patients, they have excluded patients who have for atrial fibrillation on anticoagulants, and this is most of the test trials. So if you look at the history, in 2006, the Academic Research Consortium met and they defined ischemic risk for coronary stent trials. And that provided some standardization. And in 2011, bleeding endpoints were defined, and that also proved some standardization. In 2018, finally, the Academic Research Consortium met together, about 50 researchers all over the globe, and they defined the HBR criteria. And we have to understand this HBR criteria because they are so simple to define, and the definition is binary. Now, if you look at the 1-year bleeding rates in the DAPT trials, it would typically range from 2.8% to 0.3%. So bleeding rates are low and the reason the bleeding rates are low, because the HBR, the high bleeding risk patients, are either excluded, as I told you, or underrepresented. So of late, in last 2-3 years, a lot of trials have been presented in which they have specifically included high bleeding risk patients. So particularly the global leader trial, and recently the Onyx study, which also compared various stents, and the DAPT, stop DAPT trial, involving all the types of stents, the Giant stent, the Onyx stents, and all the recent meaning trials have been very specific on the role of these DES stents in the high bleeding risk patient, and that makes a very interesting study. Now, if you look at the data and if you look at the last few years trials, leaders-free trials, leaders-free 2 trial and Zeus HBR trial and senior trial, the bleeding risk is in the range of 3.5 to 7.2%. But if you look at individually, the master DAPT trial, the Onyx trial, the Cobra reduced trial, Evolve short DAPT trial, the Science trial, the risk factors for high bleeding, age, oral antiviral, renal failure, different criteria have been used in different studies. So there is no standardization, and hence the need for this HBR trial. And you look at the various risk factors: renal failure, liver disease, cancer, anemia, thrombocytopenia, stroke, hospitalization for bleeding, NSAIDs. Well, various risk factors, various trials have used various criteria, and that is the reason why there is so much of heterogeneity in the trials. But if you look at the practice, about 20% of the PCI patients are at high bleeding risk, and their identification is of major importance, very important for day-to-day practice. And we have made it a routine that you categorize the patient whether he is high bleeding risk before you take the patient for an intervention. And we understood that there is a lack of standardization defining this population, trial design, data interpretation, clinical decision making. So now, who are the patients who are at high bleeding risk? So a very simple diagram, a very simple representation. All patients who are above 75 years of age, because of the age itself confirmed, it gives a high HBR risk. Then those patients with renal disease, those patients with liver disease, those patients with active cancer. So those patients who have comorbidities are at high bleeding risk. Those patients who have anemia and those patients who have low platelet count are typically at high bleeding risk. Past history, particularly the recent history of ischemic or bleeding, intracranial bleed, intracranial hemorrhage, arteriovenous malformation, all these patients are at high bleeding risk. Of course, those who have had bleeding history, those who are on oral anticoagulants, those who have been typically taking NSAIDs and steroids and planned surgery or DPT or recent trauma, these are all patients of high bleeding risk. Now, for the sake of simplicity, very nicely, they have defined how to measure the bleeding risk. So HBR is defined tentatively as bar 3 or 5 bleeding risk of more than 4% at the end of 1 year, and or 1% risk of intracranial hemorrhage. This is within 1 year after PCI. So this is a provisional, a tentative figure 4%, but this at least has, this is the consensus. So any person, you do 100 PCIs of patients and if the bleeding risk is more than 4%, and all those patients, they are more likely to be coming from high bleeding risk. Now, major criteria: if the bleeding risk is more than 1%, bleeding risk is more than 4% at 1 year, the bar 3 and 5, this is well defined. One can go through the literature. The ARC paper is available in circulation, and the risk of intracranial hemorrhage more than 9%. So 4% and 1% and an or major criteria. And sometimes, if the major criteria are not met, 2 minor criteria can also give increased bleeding risk. So HBR status, high bleeding status, conferred if there is a 1 major and 2 minor criteria. So what are the major and minor criteria? So those highlighted with dark blue is major criteria, and those faint blue highlighted with a very faint blue, is minor criteria. So a person, let's say 82-year-old, gets admitted. He's a HBR patient, but it is a minor criteria, and we need 2 minor criteria to categorize the patient for a HBR. So something like a patient whose age is 82 and he has hemoglobin of less than, let's say, hemoglobin is 11.2, then one minor anemia and one minor age, both these criteria confer the patient to high bleeding risk. Similarly, renal disease, moderate CKD, eGFR between 30 to 60 is mild or minor criteria, and eGFR is less than 30 is major criteria. Mind you, most of the trials have excluded such patients. Of course, liver disease, severe liver disease, cirrhosis, we know cirrhosis patients are very prone for high bleeding, major criteria. So any acute cancer, patient who has presented with the active cancer in last 12 months and is being actively treated, the high bleeding risk. Anemia, I have told you again, but to re-emphasize, hemoglobin less than 11 is major, and hemoglobin less than 13 in males and less than 12, but more than 11 is a minor criteria. Then comes a low platelet count. If the platelet count is less than 1 lakh, it is a major criteria. So these are the common clinical patients clinical patients we encounter, elderly patients, anemic patients, sometimes low platelet count, sometimes active cancer, renal in particular, they are all bleeding risk. Similarly, any patient who has had stroke in 12 months, last 12 months, a moderate or severe ischemic in 6 months, but a bleeding traumatic intestinal hemorrhage in last 12 months, it is a high bleeding risk. Of course, those with bleeding by diastasis, who had bleeding, those who had been hospitalized recently, those who had received blood transfusion, they are all high risk patients. Patients who are on long-term oral anticoagulants, mostly because of atrial fibrillation, high risk. Lastly, those patients who are on NSAIDs, steroids, are on chronic use, these patients are minor criteria, but they are high bleeding risk. Now, planned surgery on DAPT, a recent trauma surgery, and he has to undergo PCI, all these are major criteria. So very, very nicely defined and very simple to implement also. Now, I would like to highlight certain important risk factors. Age is an independent predictor for bleeding. Bleeding risk increases with age, and elderly patients tend to be underrepresented in randomized trials. We know that, and they tend to have more comorbidities and coexisting risk factors, and that is the reason probably the risk factors overlap, and that is the reason it is considered a minor risk factor. And keep in mind the biological and chronological age may differ. So age as an important risk independent predictor of bleeding. Coming to oral anticoagulant. Common indication is PCI, patient on oral anticoagulant undergoing PCI and coexisting AF. But a person who is on a vascular protection dose like a rivaroxaban 2.5 milligram OD is not considered a high risk. That is a vascular protection dose. And if you look at the few trials and a glimpse of few trials, would show that those who were on triple therapy typically had a very high bleeding risk, as is, and the West trial and ISA triple trial, the bleeding risk was almost 12%, whereas in Pioneer AF PCI it was 7.9 and G12 PCI it was 7, because these trials, they used very stringent criteria of inclusion. That's why the bleeding was less. Otherwise, West trial and ISA triple trial, the bleeding risk was almost 10%. So very important, oral anticoagulation. Coming to chronic kidney disease, risk of bleeding increases incrementally with worsening CKD, but keep in mind that as the bleeding risk increases, the ischemic risk also increases as the CKD worsens. So both risks, in fact, counterbalance each other, and that's the reason why the DAPT score, CKD is not a variable in the DAPT score. So chronic kidney disease, we have to keep in mind the ischemic and the bleeding risk balances each other. Hemoglobin less than 11, major. Hemoglobin between 11 and 12.9 and 11 and 11.9 in men and women respectively is a minor criteria, important predictor of bleeding. And in fact, in the development cohorts of number of bleeding risk scores, if you go through the various bleeding scores, consistently, anemia is one of the risk predictors for bleeding, and that has to be kept in mind. Now, what about cancer? For any person with a diagnosis within previous 12 months or ongoing active cancer treatment like surgery, radiotherapy is vulnerable for bleeding. And cancer in complete remission or requires only maintenance therapy is not considered active. And in the Leaders 3 trial, as much as 9.7% patients had cancer. So those patients are considered high bleeding. Now coming to another important criteria, previous stroke, intracranial hemorrhage. So any brain AVM, previous intracranial hemorrhage at any time, and moderate or severe ischemic stroke within 6 months before PCI is a major HBR criteria. And ischemic stroke at any time not meeting the major is a minor criteria. So yesterday we had to admit one patient who was scheduled for a PCI next week, and he got admitted with a stroke. So now this patient becomes a high bleeding risk. If it is a moderate to severe ischemic stroke, if it is a mild TI, then it is a minor criteria. It's a minor ARC, but still you have to keep that in mind. And remember, previous and pivotal DEST trials excluded patients with prior stroke within 6 months of enrollment. And the stroke patients, and it's only in the Leaders 3 and the senior trial that stroke patients were included. Similarly, what do we learn from trials of DAPT after ACS? In the Triton-TRIMI trial, ischemic hemorrhagic stroke occurred in 6.5%, and 2.3% had intracranial hemorrhage. We remember that Prasugrel is not given in patients of stroke. It is contraindicated. We remember that. Otherwise, if you look at the non-intracranial bleeding, they do not appear to differ significantly in trials of DAPT. But the intracranial bleeding, particularly one involving Prasugrel, the bleeding risks were very high. So that we have to keep in mind. So American Heart Association have said that those patients who are, those minor stroke and TI, DAPT should be initiated within 24 hours, but it is beneficial for early secondary prevention only up to the period of 90 days. So somebody has a stroke, DAPT is indicated for only 90 days, but with a minor stroke. That is very important concept to realize. So after 90 days, probably DAPT can be converted to single antiplatelet therapy. Now coming to thrombocytopenia, moderate or severe baseline thrombocytopenia, platelet count less than 1 lakh is a major ARC HBR criteria, and sometimes acquired thrombocytopenia results from post-procedure decline in platelet count in a patient without thrombocytopenia. Well, those patients who have chronic bleeding diastasis, such patients are not very common in clinical practice, and there is sincerely lack of data and low prevalence of such conditions in patients undergoing PCI. Remember, cirrhosis with portal hypertension bleeding complications are potentially catastrophic. At the same time, a patient with cirrhosis, portal hypertension who is likely to undergo liver transplantation, and if you find obstructive CAD during transplantation workup, this is a very, very challenging subset because such patients are prone for bleeding. Now, risk of stent thrombosis in patients who are planned for major non-cardiac surgery, keep in mind the first month, the risk of thrombosis is much higher as compared to the subsequent months. So avoid non-cardiac surgery planned in the first few months. And PCI after recent major surgery is also very challenging, particularly major surgery or major trauma within 30 days, high bleeding risk. Similarly, any person who is using NSAIDs and steroids for more than 4 days per week, they are, considered high bleeding risk, minor criteria, but there is paucity of data in such patients. Now, very special situation. Let's say a patient is frail. What about ethnic Indian patients? What about patients with acute coronary syndrome? Why these factors are not taken into account for HBR criteria? Because frailty means it is not included as a criterion because of the paucity of data, and advanced stage and coexisting HBR criteria may account to some degree for frailty, and that is why it is not included. Similarly, we have to keep in mind there is a greater bleeding concern in Asians, and bleeding models developed in Western populations tend to underestimate bleeding risk in Asian populations. So all these bleeding models are developed in Western population. In typically the Asian population, the weight is less, and the bleeding chances are much more. What about acute coronary syndrome? It is not a HBR criteria because the increased bleeding risk in patients with ACS is attributable to more aggressive antiplatelet therapy rather than the ACS per se, and that is why it is not included. And lastly, those patients in the leaders free and senior those HBR trials, those many patients they did not stop the DAPT after 1 month and continued to remain on DAPT, and they were found to have more bleeding. So DAPT non-adherence can also be risk factor. So these are the various. Now, what are the limitations of this HBR criteria? To summarize and to conclude, well, the chosen cutoff value of 1 year bar 3 or 5 bleeding, very nicely defined bar 3 or 5 bleeding. I would request you all to go through this. What are the criteria for 3A, B, C, and 5A and B bleeding? And if the bleeding is more than 4% and the intracranial hemorrhage more than 1%, then it is considered high bleeding risk, and data is not available for a number of criteria, and the binary criteria is used to simplify. So naturally, if a patient has more than 3 or 4 risk factors, naturally he will be at more bleeding risk. But according to this HBR criteria, there is no point scale or number of points awarded to each criteria, and maybe in subsequent editions of this ARC criteria, maybe in few years down the line, we would also get specific points for anemia, some points for stroke, some points for low platelet count, and we will be able to calculate the total risk. Similarly, further work is needed to better quantify the bleeding risk with each individual criterion and to identify potential interactions. Also, HBR status is only one side of the problem, and all clinical decisions must be based on simultaneous assessment of both bleeding as well as the thrombotic risk. If you are planning high risk intervention, intervention which involves some bifurcation left main lesion, then it becomes very challenging in such patients. Now, ARC HBR Part 2 is focusing on clinical trial design characteristics tailored to specific needs of HBR patients and assessment of trade-off between thrombotic and bleeding risk for HBR patients. So to conclude, paucity of relevant clinical data in day-to-day practice, use of heterogeneous definition have limited the interpretation, generalization, pulling of published data, but of late we have a lot of trials. ARC HBR definition will require both validation and probably recalibration. Maybe some criteria might become major, some might become minor, but to tell you, in latest Euro intervention, this ARC HBR criteria have been validated in some series of patients, so that's very good news. And finally, they have arrived, and I think they are very useful in day-to-day practice, and they provide a much-needed framework for understanding and evaluating treatment options for PCI patients at high bleeding. Thank you. These are just the revision of the criteria. So thank you very much. This is in nutshell about the HBR criteria. The reason this topic was allotted to me was because of the interest in such patients nowadays.
Thank you very much, Dr. Prashant. It was a very nice presentation.
Yeah. We'll now move on to our next talk, and that will be by Dr. Deepak Davidson. Prior to that, it's my pleasure to invite to welcome Dr. Robert Van Johns from Netherlands. Very good afternoon to you, sir. We'll have your talk in some time. We'll just continue with the next talk, sir.
Thank you very much for joining.
Yeah. Dr. Deepak Davidson, he's the Chief Interventional Cardiologist at Caritas Heart Institute, Kottayam. He's a renowned expert in complex interventional procedures and a known proctor for imaging, physiology, and root ablation. Welcome, Dr. Deepak Davidson.
Good evening to all of you. It's indeed my pleasant privilege to be with all this August gathering over here. Let me take this opportunity to thank Dr. Parvinder and Dr. Mahesh for having given me this opportunity. I bring greetings to you all from the southernmost part of India, the God's own country. Well, the topic given to me is approach to my approach to bifurcation. Every time I start thinking about a bifurcation case, the most important thing that goes through my mind is to keep the procedure extremely simple and safe for the patient. So I divide the cases into complex bifurcations and simple bifurcations. When it comes to a simple bifurcation, I would always think in terms of a provisional strategy, and when it comes to I would think in terms of a two-step strategy. Now, I'll start with the case history of a 86-year-old gentleman who presented to us with recurrent rest angina. Now, this was the angiography. You could see in the caudal image that there is a critical left main bifurcation stenosis. You could also see that the flow in the left angiodescending artery as well as the circumflex artery is reasonably okay. The circumflex proximally, it's mildly diseased. No much of critical stenosis in the proximal circumflex segment. In the cranial view also, it's very clear that it's a critical stenosis of the left main with some amount of calcification. Now, how do I go forward? Now, do we think of a provisional strategy or a two-stent strategy in this particular situation? So what I would like to know is this a simple bifurcation or a complex bifurcation? Now, based on the definition criteria, we know that it's going to be a simple bifurcation. When you want to call it as a complex bifurcation, the length of lesion that extends into the circumflex artery should be around 10 millimeters with at least 70% stenosis of the circumflex artery, which is not present in this particular situation. So I would consider this as a simple bifurcation with some amount of calcification in the left main as well as left antidescending artery. So my strategy was to consider this as a provisional strategy. Try to wire the vessels, then try to do rotablation of the left main left antidescending artery, do proper lesion modification, and then to stent right from the left main into LAD, and then decide on what needs to be done for the circumflex. So that was a strategy like. And if you look at the image down here, you would understand that this classifies to be called as a simple bifurcation. Now, we had challenges in wiring the left antidescending artery. You could see that there is a right angle over there from the left main into the circumflex artery. We wired the diagonal branch with a field run through wire, and then we tried to wire the left antidescending artery. Ultimately, with great difficulty, we could get a field FC into the left antidescending artery. Initially, our plan was to exchange it for a rota wire, but then the patient was a bit unstable, continued to have angina. You could see here that in the second image, the flow in the left antidescending arteries becomes slow. So he had slow flow angina, some amount of hemodynamic compromise. So we decided that we wouldn't go ahead with rotablation. We tried to get a balloon across and dilated. That was non-compliant balloons being dilated. Following that, angiosculpt was used to prepare the bed. And for non-compliant balloon dilatation and angiosculpt dilatation, we were able to achieve good flow in the circumflex and left antidescending artery. Because there was significant amount of dissection in the proximal left main and left antidescending, we didn't want to use an optical coherence tomography because that might further propagate the dissection over there. So we decided to do an IVS evaluation. You could see here in the upper frame that there are some breaks in the calcium. You could see it in the upper frame. You could see that at 1 o'clock, 2 o'clock position there is a break in calcium. In the second image down there, you could see that at 1 o'clock position there is break in calcium following the NC as well as angiosculpt dilatation. And so following that, we decided on stenting. So our strategy was to stent right from the left main ostium into the left antidescending artery. That's a 3.5 into 28 expedition. We had a wire in the circumflex artery. Following the stent implantation, you could see that the flow in the circumflex is reasonably good. The flow in the left antidescending artery is also good. Now, the next step was to get a pot done. Now, the most important point that one should keep in mind is the distal end of the balloon should be proximal to the carina. So that's the positioning of the balloon being done. That's a 4.5 millimeter, 4.5 into 8 millimeter balloon being positioned for the pot, and pot was done at 16 atmospheres. And following that, we tried to wire into the circumflex artery with a loop technique. So we got the wire into the circumflex artery. However, following that, we were not very sure what exactly was happening to the circumflex. Was there a significant plaque shift into the circumflex artery? The flow was good. However, the ostium of the circumflex was looking hazy. So we decided that probably we need to do physiological evaluation of the circumflex artery. So we decided on FFR. It was difficult to get the FFR wire into the circumflex artery. However, when we evaluated the circumflex artery, we found out that it was an ischemic territory. It is ischemic following the stent implantation. So we decided that probably we need to do something complex. So we dilated it and that was a tap technique. It was 3 millimeter stent being deployed there, and back the balloons did further kissing dilatation. And finally, we did the report over there. While doing report, one should be extremely careful. Make sure that the report balloon does not reach near the carina, because it might damage the stent that is protruding into the left main, the T and protrusion aspect. So always make sure that when you do a report, the report balloon should be much further away from the bifurcation. This is what could happen if the balloon is very close to the bifurcation. You could crush the stent that is protruding into the main vessel. So by doing a report, in majority of the situations, make sure that the distal end of the balloon is much away from the carina. So that's the final result. The flow is good, and you could see in the OCT that the circumflex ostium looks good, the stent was expanded, and there was no malappositions. Now, when we do a stent crossover deployment, that is when you want to stent from the left main to LED, is it mandatory that you need to kiss the bifurcation every time? We know from the data that kissing does not make a lot of difference. Whether you kiss the bifurcation or whether you don't kiss the bifurcation, the long-term outcomes are going to be similar. So how do we decide on whether we need to do kissing balloon dilatation of the bifurcation following a crossover stenting from the left main into left antidescending artery? This was a patient who had undergone a left main stenting from crossover stenting from left main to LED. 3 years down the line, he presented with an acute coronary syndrome. You can see that the circumflex mouth looks bad, and when we did the OCT run from the LED to the left main, you could see that there is fenestrated restenosis. You could see here that there are so many struts across the ostium in the circumflex, and there is significant amount of new intima grown over those struts over there. So you could see that these sort of fenestrated restenosis at times do happen. Ultimately, we had to settle down with a keloid stenting of the circumflex and got away in that particular situation. So what do we decide about the struts at the side branch mouth? Now, we mainly do most of our bifurcation cases, we try to do CT evaluation at the end of the procedure, even following crossover stenting. If we see something similar to this, in this particular situation, you see that there are so many links and so many crowns across the circumflex ostium. So when you see this sort of situation in an OCT, we would definitely go ahead. Wire, you could see here that the wire is gone through the proximal cells into the side branch. We would try to get the wire into the distal cell and try to do a gentle bifurcation dilatation, kissing balloon dilatation. This is another example. You could see here that the LED ostium is diseased. There is a long LED disease. We stented right from the left main ostium into the left anterior descending artery and did a pot. And following the pot, you could see here that the result looks good. Angiographically, it looks perfect. And you could also see in the OCT image that at the ostium of the circumflex, there is no significant amount of crowns, there is no significant links over there. So in those situations, probably we need to try to avoid kissing balloon dilatation. So in many situations, when you have significant amount of links or struts across the mouth of the circumflex, probably you need to do a kissing balloon dilatation. Or so based on imaging, one could decide on this particular aspect. So when you have a patient who has got a simple bifurcation, try to keep things very simple. Use a 7 French guide catheter, prepare the lesion well with probably rotablation if it's a calcified lesion, angiosculpt, angioscope. All those things could be used for proper preparation of the lesion. Then always try to do imaging for the bifurcation. Physiology, whenever you feel is ideal, and try to always follow the basics. When you do a pot, make sure that the pot balloon, the distal tip is exactly proximal to the carina. Do proper kiss, proper report. When you do report, make sure that the report balloon is much away from the bifurcation. Now, coming to complex bifurcation, when you have a case of complex bifurcation, always think in terms of a meticulous 2 stents technique. We always prefer trying to do DK crush, but when you look at the definition to try, almost 77% of patients underwent DK crush, and almost 20% of patients they were taken up for a culotte technique. Now, this is a patient, 68-year-old, who had an interstitial lung disease, recurrent left ventricular failure, a dominant left circumflex artery. You can see that there is a left main bifurcation disease. There is a long disease of the circumflex ostium, very critical dominant vessel. So now this qualifies to be called as a complex left main bifurcation. So you could see here that there is significant amount of calcium. There is long disease of the circumflex ostium, long disease of the left anterior descending artery. So in this particular situation, we are committed to 2-stent strategy right from the beginning. You could see in the first image that there is so much of calcium there. The lung fields are looking bad. So we decided on rotablation rotablation of, we started with left-hand descending artery. It was in 1.5 millimeter bore at 180,000 RPM, and following increasing the RPM, we were able to cross the distal segment. Following that, rotablation of the circumflex was even more difficult. We went at 180,000 RPM. It was not going through. Patient developed slow flow during the procedure. We had to push in a temporary pacemaker, and following that, we continued rotablation, and at 200,000 RPM, we were finally able to get into the circumflex artery. That's at 200,000 RPM. And once we did the rotablation, we were able to achieve good flow in the circumflex artery, and the AV block disappeared. And then we were committed to stenting of the bifurcation. So we decided on DK crush technique. Following proper balloon dilatation of the bifurcation, we stented the circumflex right at the ostium, and following stenting, the second image shows that the stent is being, and following that, we recrossed into the side branch. As the data says that recrossing into the side branch should probably done through the proximal cells in the first crossing. This is the first crossing. So you could see here in the OCT run that the wire which is coming from the left main, it's gone into the side branch through the most proximal cells. So the wire has gone through the proximal cells. Following that, we did the kissing balloon dilatation. The first kissing balloon dilatation was done. Following that, we stented the left main into the LAD, and then the second rewiring. It was recommended way back in 2018 that probably you need to try going the second time also through the proximal cells. But the problem is when you try going through the proximal cells, you tend to have a metal carina. So final kissing balloon dilatation. So proximal optimization, and the result was looking perfect. The flow in the circumflex as well as the left antidescending artery was good. However, when you look at the OCT run, you could see here that at the bifurcation there is a huge big chunk of metal sitting over there. That's a huge neocarina that has been formed, primarily because the second wiring was through the proximal. So that was the reason wherein you could see here that in this bifurcation, the circumflex ostium looks good. However, you could see that there is a significant amount of metal carina over there. So making us understand that probably when you do a DK crush technique, the second crossing one should try to get the wire through the distal cell rather than through the proximal cells. Now, again, while doing bifurcations, one should try to modify the technique so that you tend to have better outcomes with whatever technique you do, with either DK crush or with the culotte technique. Whatever you do, probably you need to try modify the technique so that the stent is well opposed, so that the long-term outcomes are better. Now, what modifications can be done to DK crush technique? When you look at the EBC recommendation, always try to have a very high pressure dilatation of the side branch ostia prior to kissing balloon dilatation. That's number one. Number two is when you want to cross into the side branch the second time, the second crossing should probably be a distal recross. Here in this image, you could see here that the stent has been crushed, and following that, the wire is going through the proximal cells. Now, following the second stent implantation, when you try to recross into the side branch, it's always good that you try to recross through the most distal cell, making sure that it up luminal so that you wouldn't have significant amount of neocarina at the bifurcation. This was a 44-year-old chap who had a bypass surgery, had grafts occluded. You could see that there is a very critical left main bifurcation. So in this particular situation, we decided that when we cross into the circumflex, the first time during DK crush, we would go proximally, and the second recrossing, as seen in the OCT image down there, you could see that the stenting has been done from the left main to LAD, and we have tried to recross into the circumflex branch. You could see that the wire has gone exactly through the distal cell, and following that, you could see that the flow in the LAD L6 is perfect. And you could also see when you look at the bifurcation, the carina looks excellent. There is no significant metal at the carina, and the circumflex ostium looks good. Just to highlight the fact that the second recrossing into the circumflex, when you do a DK crush, probably one should try to get the wire through the distal cells. And when the additional advantage of OCT would be when you do the imaging, you would identify complications that you wouldn't identify during an angiographic imaging. You could see here that there is some amount of stent distortion due to the guide catheter hitting at the ostium from the left main. So that also was taken care of. A part was done, and finally we were able to achieve a good result. Just to highlight the fact that imaging would help us to go a long way in managing these particular patients with bifurcation stenosis. Now, at another point that should be kept in mind, the EBC recommends that when you crush the stent in the side branch, we always try to do crushing with one balloon. Now, they recommend that if you could do the crushing with two balloons, it will be better for the patient. This is just an example to highlight the fact this particular patient, you could see that there is a bifurcation stenosis. stenosis, left main bifurcation stenosis, LAD ostium as well as the circumflex ostium is significantly diseased. So we went ahead with DK crush, wired, but dilated. And following that, in the first image, you could see that the stent is being deployed in the circumflex ostium. And the second image, you could see that we are crushing it. Now, normally when we crush the stent in the circumflex, we would crush it with a balloon that is matched for the distal main vessel. Now, this is a 3 millimeter LAD, so we have taken a 3 millimeter balloon in the left main to LAD for crushing the stent. Now, if you concentrate on the lower frame, the OCT image, you could see here that the stent is not well crushed. You could see that there are 2 layers of stent sitting at the left main part. You could see that the stent is not properly crushed to the walls of the left main, just because the balloon that was taken was a 3 millimeter balloon in the LAD to left main. So what the EBC recommends is, now before you recross into the side branch, you could take a much bigger balloon the second time. You could take a 4 millimeter balloon or a 4.5 millimeter balloon, dilate it once again, so that whatever stent is crushed, you crush it properly, you oppose it properly, so that you have final better opposition of the stent. So this is how it is. If you look at this cartoon, normally when you crush the stent into the circumflex, you take a balloon that is matched for the LED size, so that following crushing, you tend to see 2 layers of stent in the left main. So you want to avoid the 2 layers of stent in the left main before you cross into the side branch. So you could take a much bigger balloon, dilate it so that you crush it really well, and then you could recross into the side branch. And then, so the idea is you tend to have a better opposition of the stent while managing. Then finally we go through all the steps, and finally we will able to achieve a good flow in the vessel. The angiographic result, as well as that's OCT imaging, which shows us that the stent is well opposed, the circumflex ostium looks good, and the mouth and the carina also looks better. Now again, when you compare DK crush versus culotte technique, we know that DK crush does better compared to culotte technique in the long run. The reason being, this is one explanation for that. If you look at the first image, you could see that following a DK crush technique, the confluence looks extremely bigger. But if you look at the second image following a culotte technique, the confluence doesn't look much bigger. There is a napkin ring constriction over there. So this constriction probably could be the reason why the maze is more with culotte technique. So how do you manage the culotte technique? You could, if you were to do a culotte technique for the bifurcation, probably you need to make few modification, probably 2 or 3 modifications. One, always try to do an inverted culotte technique. Inverted means you first tend the side branch. The second important point is make it a mini overlap. Normally we would like to have 8 millimeters, 10 millimeter overlap in the main vessel, but try to reduce the overlap in the main vessel to less than 5 millimeters. That is mini culotte. And then always try to do double kiss before you deploy the stent. Normally we do one kissing balloon dilatation following the main stent implantation. But in this technique, when you want to do a DK mini culotte technique, always do a balloon dilatation prior to implantation of the second stent. The idea of having these 2 things, that is mini overlap with double kiss, would be you tend to have a better stent apposition. The micro CT studies have proven that you tend to have a better apposition, and even the fluid dynamic studies have shown that when you do a mini DK culotte technique, you would have a stent apposition compared to the regular culotte technique. Just an example, and I'll stop with that. This is a patient who presents with a lateral myocardial infarction. You could see that the diagonal branch, it's a huge one. It's a 3 millimeter vessel, is totally occluded over there. And you could see that there is some amount of haziness in the LAD also. It's around 50% stenosis at the LAD. So we wired LAD as well as the diagonal branch. We dilated it. You see that the diagonal is a huge vessel. That's almost 3 millimeter vessel. So we decided to do a mini DK mini culotte technique in this particular situation. So we stented the diagonal branch with a 3 millimeter stent, which is protruding less than 5 millimeter into the main vessel. That is a stent being deployed. Following that, we did a proximal optimization. That's the proximal optimization being done with millimeter balloon there, and following that we recrossed into the LAD through the distal cells and tried to do an OCT run. And in the OCT run, low down there, you could see that the overlap of the stent in the main vessel is less than 5 millimeter, which was clearly proven. And following for entered with a 4 millimeter balloon, and following the second part, we recrossed into the diagonal branch, the second kissing balloon dilatation, the third part was done, and finally the result looks perfect. So this is how one could modify the culotte technique into an inverted decay mini culotte so that the long-term outcomes could be significantly improved in patients following this sort of culotte technique. In the angiograph, in the OCT image, finally you could see here that the diagonal branch looks extremely good. There is no significant metal canina, and even you could see that the confluence looks wide. And the data says that when you do something like this decay mini culotte technique, you oppose the cell well to the vessel wall and you achieve good results. So finally, regarding imaging, I would prefer imaging for all bifurcation, not to miss complications. I have few examples for that, but because of want of time, I would stop at that. Thank you so much once again for the opportunity given. Thank you.
Dr. Mahesh, your mic is off.
Yeah.
Thank you, Dr. Deepak. This was an excellent presentation, and you made the bifurcation techniques look so simple. And the diagram presentation was very nice. It's very good for the young cardiologists who would be watching, and it has helped simplify, because bifurcation techniques have always been very confusing, and the nomenclature also has been very confusing. You have done an excellent job in simplifying that. We would like to take up a couple of questions from anyone in the panel.
See, for simple bifurcation, you said provisional stenting is better. But from your lecture, other lecture, we realize that a lot of time there's a neointimal hyperplasia of the side branch. So when we don't do the imaging, should we consider routine dilatation of side branch, even if there is no TME compromise, FFR is negative, just to avoid intimal hyperplasia of the stent, which may be probably projecting? Just one-to-one dilatation, very subtle dilatation.
It's a very, very true, sir. When we look at the data says that if you do kissing balloon dilatation or not do kissing balloon dilatation in the long term, they do not behave differently. But over the last 2 to 3 years, as we do more and more imaging of the bifurcation, as we do more and more OCT of the bifurcation, we do see this sort of novel imperfections, like this sort of perforated restenosis of the side branch. So looking at all these images at this point of time, when we do not have significant imaging modality, when we do not have an OCT imaging modality in your center, and when you are doing a left main bifurcation crossover stenting, probably one should try to do a small kissing balloon dilatation at low pressure so that you're removing the cells, you're removing the struts away from the mouth of the circumflex. What about Dr. Van Guin's opinion?
No, I couldn't follow the whole discussion. I was having my own question, so I'm sure there's a moment on it. Imaging is helpful to understand the struts on your side branch, and I think you would make that very clear with your images. I also noticed I did miss your explanation why you want to do 5 millimeters of double stenting branch, because most of our pot balloons are something like 8 millimeter long. So then you have the risk of inflating outside. So maybe you can repeat that argument for me and the rest of the audience.
Yeah, it's actually the reasoning is very simple. You want to have very, very less of metal protruding from the side branch into the main vessel. So you limit it to less than 5 millimeter. Now, when you do a pot with a 6 millimeter or an 8 millimeter balloon, you have a proximal geographic miss. But that particular area you're already planning to cover with the second stent, which is going from the proximal main vessel to the distal main vessel. So primarily, it's like the stent that comes from the side branch. It's protruding minimally into into the main vessel. You're not bothered about the geographic miss during the pot just because you're going to cover that particular area, the geographic miss area, with the second stent. And when you deploy the second stent, you deploy the second stent in such a way that you're at least 8 millimeter, 10 millimeters proximal to the bifurcation, so that you can have an aggressive pot done with a much bigger balloon without any geographic miss. So ultimately, the idea of having very minimal stent being protruding into the main vessel and doing a second kissing balloon dilatation, based on these micro CT studies and based on the fluid dynamic studies, we come to know that the stent is well opposed and the shear stress is significantly less, so that they could do better in the long term run, even though we do not have any clinical studies comparing these particular techniques.
Absolutely. So the short answer is be sure that your second stent is at least 8 millimeter covering the proximal main branch, so then you
Of
can
course.
do the opposite. Absolutely. Thank you for making that clear.
I have one question. For decay crush technique, you mentioned for the first kissing balloon, you cross from the proximal cell, and for the second kissing, you cross from the distal cell. The main advantage of one of the advantages of decay crush technique is that you are able to do successful kissing balloon dilatation in most of the patients. But if you change the first kissing and second kissing, do you think that will affect the successfulness of doing final kissing balloon technique?
So that's not an issue at all, primarily because during the first kiss, you're looking at the stent that is crushed in the circumflex. You cross through the proximal cells into the circumflex, you do a kissing balloon dilatation. Now your circumflex mouth looks really good. It's a circular circumflex mouth. Now you deploy the second stent from the LAD into the left main, and now this stent is exactly over the fully open circumflex mouth. Now you want to recross into the circumflex. Now you have to cross only through the struts of the stent which comes from the LAD into the left main. So you have proximal cells, the mid cells, or the distal cell. Avoid the proximal cell, try to go through the mid or the distal cell. Anyway, you're crossing through only one layer of stent. So when you do a kissing balloon dilatation, it's definitely not going to make a difference at all.
That's great. Thank you very much. We'll go on to our next talk. That's by Dr. Pratap Kumar. He's the Chief Interventional Cardiologist and Chairman of Mediterranean Group of Hospitals. He's a pioneer in chronic total occlusions in India and has performed over 1,200 CTO cases, with almost 10% of them being done retrograde. He's the president and founder director of Complex Interventional Group, that is the Indo-Japanese CTO Club. He regularly conducts complex PCI workshops at Mediterranean hospitals, and he's trained over 75 cardiologists in various interventional techniques. I welcome Dr. Pratap Kumar for his talk on my approach to various complex cases. Dr. Pratap Kumar. Let's check if it is online. Dr. Pratap Kumar, you're showing here online.
Dr. Pratap Kumar, are you there?
I think probably he's not there. Probably he's expecting Dr. Roberts' talk.
Yeah, fine. I think Dr. Robert.
Yeah. Dr. Robert, are you ready, or would you start the talk after some time, or are you ready for the talk?
Hi there, good afternoon. I'm ready, although for the moment I have pretty much a lot of slides. So we have to see, you have to stop me if I go over my timing. But on the other hand, I could share this, what I have at this moment with you, which I think is very valuable, because the other presentation is not there yet as well. And some of my topics are already covered just before. So if you're already happy to hear me, then I'll present my my topic on platelet inhibitions, durations, etc., which might just have a little bit of overlap. Should I share my screen with you?
Yes, sir. Yes, sir. Yes, sir. Please go ahead, sir.
I can hear you, but sometimes I cannot see anybody there. I'm hearing sounds. My face is not there. Actually, mute is written, and is a problem.
Dr. Robert, we can go ahead with your talk, sir.
Okay, I can see it. Connect video. Looking. My talk is already ready.
I think it should be sharing now, right now.
My God.
See my screen?
Yeah, we can see your screen.
Oh, so thank you very much, because I haven't even double log in, so I think you should see my screen as well. But, I should be able to.
Dr. Robert, we are not able to see your screen.
Not yet. I will share full screen, and then again. I cannot see a video.
Once you click the share button, another window pops up, and you have to click on to that particular window once again, and then again say OK.
I know, but somehow it is hidden in one of my other screens. Probably I have too many things open for the moment, so try to find out why it doesn't pop up as you explained to me.
Dr. Robert, it's showing your login from two different screens. So
I know. I'm trying to see my other the presentation at the meantime from the other computer, but this is the Cisco WebEx meeting. That one should do it, because you can hear me and you should be able to get me, but somehow I try to stop it for the moment, so just to see if I can start it again, but I don't know why. I think I'm just going to leave it for a minute, because somehow I have hidden the whole session. I should be minute.
He's actually logged in from another device also.
yes, I think so. Dr. Robert has quit the meeting and he rejoined again. Might be
Okay.
So I think meantime,
we can go ahead for the next talk. Dr. Hiramat, would be fine for you to start the talk, sir?
Dr. Hemant, your mic is off.
Dr. Hiramat, can I invite you for the talk? Yes.
Yeah,
Right. I'll just have a brief introduction for Dr. Hiramat. He's the director of the CAT lab at Ruby Hall, Pune. He has been the president of All India CSI 2017. He's a well-known speaker at various national and international conferences. He's proctored many interventional cardiologists and has given live courses across the globe. He has a great experience in peripheral interventions also, and he's participated in numerous major groundbreaking trials. May I welcome Dr. Hiramat for his talk. He will be talking on things to ensure while doing complex PCI.
We're talking as to how to prepare for some complex work. And I'm just trying to get to full screen. All right. We are set. I'm going to show you some left main trifurcation, total 4 of them, and how things change. How things change from one case to other. So, as you can see here, this is case 1 and case 2. Both have trifurcation disease, one here and one here. The important story is both these circumflex branches are dominant vessel. So circulation to the right is reasonably small, and most of the circulation is dependent on the left system. So whatever you plan, need to plan properly so that this supply to the dominant circumflex is not compromised when you put a stent in this area. So in this case, we do an FFR to the circumflex, while this case 2, the FFR is positive, while in this case, FFR is negative, which again tells me that in this case, if I end up stenting LAD and the ramus and do this as provisional, I think we are reasonable. Well, in this particular case, whatever these lesions are, they are not critical on angiogram, but on FFR, they're significant. Probably you need to stent all the way down to this point, beyond which the vessel is quite healthy. This would be a 3-vessel angioplasty, while this would be a 2-vessel angioplasty based on the FFR. So in this particular case, where you had planned a 2-vessel angioplasty, you can see you must have a good plan. You can see in spider view, this is a very acute angle from left main to LAD. So whenever you have something like this and you want to say on contrast, I generally come with Filter XT and a microcatheter, take out Filter XT and then go with a standard wire. So in this particular case, we do that. The plan is to put a left main LAD stent, and there was a lesion in the diagonal. We thought we'd ignore this and then put a stent in ramus, and then take a call on the circumflex. So in this particular case, we do stent from left main to LAD. Then we do a pot. And after doing a pot, we put a wire in the ramus and then do a TN protrusion. See, when you do a stent, single stent, where LAD's diameter is going to be much smaller compared to the main diameter, or choose a stent, and the length should be, even there is no receipt, much the left main, you must keep 8 millimeter, which is the shortest length balloon available to most of us for doing a pot. So accordingly, a sizable length of stent is placed in the left main. After doing a pot, you wire the ramus, and then you do sort of a post dilatation to the remaining portion of the stent. So after doing the NC dilatation to the deployed LED left main stent, you start working on the ramus, work with a small balloon, then the non-compliant balloon. I always like to take non-compliant balloon when you are going to do a tap, primarily because the ostium is the one which must get a good stretch. And most of us, after deploying the stent in the ramus, we bring back the same balloon and kiss with the balloon in main branch. This is a stent deployed at about 6 or 8. Then you bring it back and then do simultaneous inflation on the balloon. But definitely a higher inflation pressure on the balloon side branch, because we are not going to bring back a non-compliant balloon to stretch the stent further. At the end of this, you can do FFR to the circumflex, and FFR to circumflex is 0.98, which means we can leave it alone. So while doing this, most of the time we like to get a regular wire and then the help of microcatheter and the wire. When you are doing pot, after doing a tap, make sure that the distal end of the balloon doesn't hurt the back protruding portion of the side branch stent. So in this case, you must make sure taking stent boosts that your stent is not hurting the protruding portion of at the back end of the stent. So this is the case done with 2 stents. The left main LED was placed first and then tapped to the ramus. And then we have done FFR to the circumflex branch. No doubt the mouth looks a little bit pinched, but as you saw, FFR was 0.98. So we were quite happy leaving this unaddressed. These are the steps. This is how we started. This is how we ended. And these are the 2 stents placed in this particular vessel. Now we move to the second case, which looks reasonably similar to this case, the dominant circumflex. But here the FFR is positive. So the plan is to put stents in these 3 vessels. You can see a positive FFR here. So what strategy do you use? Our plan was to do a decay crush. The main stent we thought will go from left main to LED, which was matching diameter compared to the left main and also a dominant vessel. And then we decided to put a diagonal the OM as well as LED as the side branch. So the first stent was in LED, then do a decay crush, then put another stent in the second branch, that is the OM branch, or you can put a second stent here and then third stent as a tap. I think this is what we planned actually, that we'll do a decay crush with the LED stent, put a main branch stent towards circumflex, and then come in with a tap to the OM branch. This could have been the other technique. You do a mini crush to LED, mini crush to OM, and then put a third stent left main to circumflex, and then do a final case. So there are various ways you could have done this case, but this is what we finally chose, that we will do the decay crush to LED. So LED stent is now placed, deployed, and we are trying to do a decay crush. I think the stent in the main branch probably was a little bit too distal. And what happens is, of course, it must have crushed the ready stent which was protruding back, but we lost flow in the OM branch. So this branch was at this stage not wired, and we are actually doing a live to one of the meetings. So here, the important thing is to quickly wire the OM branch, which we did. Quickly wire the OM branch to a balloon, establish flow. Once we have flow, you're quite safe. And this is the time you start reviewing what would be the change of strategy that you want to adopt. Clearly, since we had lost the flow and we established a flow, we thought we must put a stent in the side branch first. This first stent was a DK crush. We thought we'll do a stenting of the OM, but we'll do probably a mini crush and then do a third stent towards circumflex and then do a mini crush. So here, after preparing the bed, we are deploying the stent in the OM. At the same time, we have stent ready in the left main to circumflex. So once you have a decent flow, making sure there is no distal dissection, you're okay to pull back this wire, and you can now deploy the stent from left main to circumflex. This is the three stents are all deployed. All vessels are now showing a reasonable flow. So now we are in a strong position to make a final kissing and good results. So at this stage, you can do a pot. So this is a pot is done, and then you first wire the LAT. Then you bring the pot balloon to the a little bit distal at the mouth of the OM branch, and then you wire the OM branch. You can see here the balloon is brought a little bit distal at the beginning of the OM stent, and then you are wiring. So pot is actually to expand the stent, of course, but pot also helps to get into the side branch more easily. And this is what is seen here, that you do a pot, wire the LAD, you do another pot, a little bit distally, wire the OM. So you are in a strong position to kiss, and this was achieved by first doing a distal kiss between the OM and the circumflex, and then doing a kiss between LAD and the circumflex. And then sorry. And you can see the flows looking very good. You can see even on stent boost, the DK crush was attempted at this point, so a little bit more metal here. This was a mini crush, so very little metal at the site of mini crush. The stents look well expanded, well seen on the angiogram too. And at this stage, this is how we have achieved. This was to begin with, and this is the way we have stented. So attempted DK crush turned out to be probably a mini crush in LAD, then a mini crush in the OM, and then a double kiss for the vessel. We can see even on stent boost, the stent expansion in the left main looks very good. You can see on angiogram here, and both side branches showing a good flows. This is the difference between these two cases based on FFR. So in the first case, you saw we ended up with only two stents. FFR was negative on circumflex. While in the second case, we ended up with two stents in the side branch. Actually, LAD we are treating as a side branch because circ was a very dominant fixed circulation. And then we ended up with a kiss here and then a kiss here. So you may have to change your strategy based on what you're dealing with. Now I'm going to show you another two cases, again, a left main trifurcation. This was a hot case, almost 1 month history of recurrent angina. Every night patient was undergoing angina. He was basically placed for surgery. However, I think PA pressures were something like 70, systolic, diastolic was nearing 40. So it was relatively poor LV relaxation. And then this trifurcation. So when the surgeon probably explained the risk to the patient probably felt surgery is too risky, and that's how he was in the cath lab. So fortunately for us, the right is big dominant vessel. The lesion in the mid is not very critical. And so we have to have a strategy. Now, whenever you have important side branches, like here, you have can make either a circumflex side branch or LAD as a side branch. We thought we'll make LAD as a side branch because, again, circumflex was a very big dominant circulation, and LV had an anterior wall compromise. So our strategy was to put stent in the diagonal first. Now you have to decide whether this branch, which is looking like a ramus, is a branch towards LAD or branch towards circumflex. We thought it was a branch towards LAD, and we are going to call it as a diagonal branch. You put first side branch stent to second side branch stent, and this is the main branch stent. We are calling it 4 because we placed the mid of circumflex first. This is how the plan was. So whenever you have a compromise like this, I mean, there could be many other ways, including first putting this stent and then attaching 2 more stents. But generally, whenever vessels are calcified, I hate doing TAP because you can never get the expansion that you would get as you would get with a non-compliant. So imaging is required, however, due to very unstable hemodynamics, we thought we will skip it. And this was the strategy we thought we'd adopt. I always like to play it safe, and that's why I always put stents in the side branch. And once you achieve 3 stents, then you concentrate on getting a final case. So most of the time, I like to use a long sheet and a 7 French guide catheter. Here you have PA pressure with a Swangan's, monitor hemodynamics and titrate nitroglycerin, etc. accordingly. You have a balloon pump placed. So all this is done right at the beginning, considering the complexity and again a possibility that if we do rota, they could be slow and so on. So in this particular case, this is how the patient is ready. We again, I choose Fielder XT with the microcatheter just to save time many times. I know this is a CTO wire, but it goes in very easily. You take a microcatheter. See, there is an acute bend here, and you to go through, it saves time. And then with the sheet, we exchange to a rota wire. So we did rota with a 1.75 burr, which is generally a bigger burr for our lab. Most of our burrs are 1.5, but it all depends on the vessel size here. Once having done that, again, I'm using a Fielder X wire to go through the bend. So if you are going through the bend and if you want to slip forward, I like Fielder FC also, but generally I prefer XT. You have to be a little bit more careful. Now we have achieved a wiring to all the branches. We first deployed a stent and this side. You can see here it is marked. So this was a stent placed here on extent. So after putting that stent, we are preparing the back portion. So we didn't want to take out any wires after doing the rota. So we prefer using an OPN balloon. So this is sort of, because of its speciality, going to high pressure, and we had already done a rotablator. So opium balloon gives a very good sort of stretch at the distality of the left main, which was the most critical region, and then moving towards circumflex and moving towards the LAD. So at this stage, we have put stent in the diagonal, and then a stent kept ready in the LAD. You deploy the diagonal stent, pull it back, go on high pressure, make sure there is no distal dissection, and you remove that wire and balloon. So now you're ready to deploy the LAD stent. Now at this stage, you have a stent placed from left main to circumflex. Always make sure not to leave a little space between the first deployed stent. So our stent from left main is actually going a few millimeters into the first deployed stent in the circumflex. So here you do deployment of the LAD stent. The stent is placed in the circumflex but undeflated at this stage. Now, at this stage, make sure there is no dissection into the distal vessel, and you can pull out the wire in the LAD. So this is what I was telling you. This is the stent which was placed in the circumflex as a first stent. And the second stent, I always like to make a contact between these two stents. There is no point leaving 2 millimeters gap between these two stents. If you are into that stent, you can stretch the whole stent with a high pressure inflation. And this is what I like to do when your stents are coming close to each other. So this is the sequence. First stent was placed here, number 1. Second stent in the diagonals, third one in the LAD, and fourth one in left main circumflex. This is how you're looking. What we have achieved is 3 stents in 3 vessels, so we are at least safe. Even if you miss the final kiss, it's fine with me. But at least you have a stent in location, and missing kiss may or may not be very crucial. At this stage, you do pot, wire the and then you wire the down. So this is achieved, and then you do a kiss between LAD and D1, as you can see here, and then you do a kiss between LAD and circumflex, and then you do stretching of these stents with the NC balloon, and then a final pot with this 5O balloon. And this is the final result that you have achieved. A very dominant, important circumflex, left main stent going towards circumflex, and 2 stents attached, one in diagonal, one in left main, in this particular position. So when you worry about difference between decay crush and a mini crush, most of the time the worry is not getting a good metal-to-metal contact, and second is missing out on a final kiss. However, if you are doing pot aggressively every time you put a stent, the wiring of the side branch is always easy. And even with mini crush, I think our percentage of missing out on final kiss is very, very low, maybe just about 1 or 2%. This is the final result on this patient with severe hemodynamic compromise, high PA pressure, mitral regurg, though the LV ejection itself was not looking too bad. The mitral regurg also settled after we put this revascularization, and PA pressures improved. So this was a complex trifurcation with hemodynamic compromise and severe ongoing angina. And let me show you one final case. This was a 36-year-old, came with unstable angina, and probably the RCA was the culprit. So this was fixed first, and you can see a very dominant vessel. So this was a 4O vessel. So we are quite happy fixing up the simple lesion and then moving towards the complexity. So we can see again a trifurcation lesion, Here again, the OM branch is a branch clearly from the circumflex, which is again a very dominant vessel. You can call this as an OM2, but this is a branch of OM1, OM2, and the native circumflex form. Whichever you want to call it, the circumflex is the important circulation. And here, all three vessels are showing important narrowing. There is narrowing at the mouth of LAD, OM1, and also the mouth of circumflex, which is running into OM2. So, which one you are going to treat as main branch? You treat LAD as your main branch. You treat circumflex as our main branch. You see the diameter. OM2 or circumflex is probably a bigger diameter vessel matching the size of the fish. Most of the time, we like to do OCT. Again, principally the same technique that always secure the side branches first. Like in this case, we have placed the, I mean, these were the options, ways in which you could have done this. Could have done DK crush, you could have done mini crush, culottes. So whatever you're familiar with, but don't miss out on stenting of the side branch. That would be my very strong, honest statement to all younger ones who are trying to attempt these kind of complex cases. So we wired all the three vessels, as you can see here. Then we use a scoring balloon 3.5 both to LAD and the circumflex. Now here we didn't think of using rotablator, and once you are not going to use rotablator, it's safe to put all your wires in and then use the cutting balloon or scoring balloon. So once we have done that, we are going to do a sort of mini crush between the OM1 and the circumflex. So this should be your position. The back end marking marker just about inside main branch, and then stent is ready in the circumflex, but this is the one which is going to get deployed. So the side branch stent, that's the OM1 stent, is deployed here, and you can see good flows, no dissection, ready to pull out that wire. Now you can adjust the position of the circumflex stent, and at this stage, main branch stent, which is going towards LAD, is also brought in place. This is also important because if you happen to get this stent back a little bit, your next stent may not cross easily and you waste time and struggle a little bit. So I always like to have a stent placed here. We had already prepared the bed with a scoring balloon at this stage. So we deploy the circumflex stent. The LAD stent is ready, but not deployed. So once having done that, so both the side branches stents are achieved, then we concentrate on the main stent from left main to LAD. I always like to take this LAO cranial, steep cranial view, and then double check in epicranial view the ostial position. Many people start stent about 2 millimeters, 3 millimeters inside, but it's never a great idea. The worry is that the next stent may not go in, or next balloon for post dilatation may not go in if you place an ostial stent. But always get the stent back in the ostium. You can take help of this balloon, stent balloon, and sort of re-engage the guide catheter and align it before you pull the stent balloon back. So having deployed the stent, the guide catheter is reasonably well aligned by this technique. You don't hurt the back end of the protruding stent, and you are looking reasonably good. I mean, the flows in all the three vessels is good. So at this stage, you do a pot. After doing a pot, you wire, you do a kiss between the OM and the circumflex, and then a kiss between LAD and the circumflex, and then you do a again here, since the trans stent is going for a balloon to the point where the circumflex stent is placed. This is the final result. You can see all three vessels are going. So in effect, we have seen two more cases. This is an OCT, and I think I will show you the cut images. But you can see here the distal stent position is very good. Somewhere in the middle of the LAD, the stent position is good. This is where the circumflex stent is originating, and you can see the expansion of the stent, again, very good, and left main area is outstanding. So we feel quite happy. Now, don't ignore stent boost. I think, in my thinking, it's a very, very good tool. You can see everything here. You can see the beginning of the circumflex stent, beginning of the OM stent, and there is a very good metal-to-metal contact. In fact, this metal-to-metal contact is very important to avoid stent thrombosis and avoid distal late ISR. So stent boost, again, very useful. Of course, OCT is the thing of today. And in this case, again, we have placed 3 stents. The dominant stent here is from left main to LAD. So I'm never shy in putting left main stent towards circumflex if it is a large vessel. Though we cannot go only by LAD size. I think LAD gives so many septal perforators that the quantum of supply coming from LADs. So LAD always a priority, but if circumflex is the dominant vessel, don't hesitate to put your stent towards circumflex. This is how we started, and this is how we ended getting good supply. So these are the 2 cases which we did for a comparison. This is the one which needed rota, and he was hemodynamically severely compromised. While this was a more stable patient, and we did not have to use any rotablator, but we used OPN on this particular case. And this is how the stenting strategy. In this case, the first stent in diagonal, second one in LAD, and third one here, and then you go back and do final case. While in this particular case, the first stent was M, second one was in circumflex, and the third one. So in these 4 cases, I've tried to show you the different techniques. So you need to sort of spend time with everybody, including anesthetic, as what steps are going to take. You have to be quick, and you should not be using too much contrast when you are using this. Do I have time for one more case, Dr.
I think you can briefly go little faster.
Right.
Go ahead with one more case.
I will make this case very quick. This was a 47-year-old lady, no risk factors, anterior MR. She presented. You can see the story. Patient was taken to cath lab in another hospital, and this was the lesion. So the operator felt that the LAD is obviously the culprit, but not a critical lesion. The right was normal, and the patient was conserved, and no stent was placed. Patient, however, 1 month later has come with an inferior wall infarction. And at this stage of time, the RCA, which was normal 1 month back, is showing important lesion. So this is 1 month. 1 month back, the vessel was normal, as I would show you. This was when he presented with an anterior MI, and this is 1 month later when he presents with an anterior. So what can happen so quickly? And most of us would probably think of dissection as a strong possibility. So this was again in an outside hospital. So the operator has placed wire into the PD, did thrombus aspiration, give intracoronary GP blockers, placed 2 stents, and you can see the dissection at the end of this extending into the distal vessel. I think he put only 1 stent, and this was the stent that was placed. And you could see a little. I think the movies are running now, and anyway, the important point is the beginning of the dissection was very well covered, and distal dissection was left for medical treatment. However, at this stage, when the I think I have some problem. Let me see how long it's going to take, if it is going to take long. Let me tell you the story. At this time, the LAD, which was not too bad, sorry. I think we are having problem here. So let me tell you the story. When the inferior MI happened and right was stented, LAD dissection, it was very clear even on the angiogram, the dissection was. So we did OCT and we fixed the LAD. This was a case, a young lady, a dissection in the LAD, dissection in the RCA 1 month later, both giving her MI. Fortunately, LV was well preserved, but the OCT clearly showed a very nice dissection. Happy covered. Thank you indeed for the attention, and thank you for the opportunity.
Thank you, Dr. Thank you, Dr. Hiremat.
Baroda.
It was a very, very nice, presentation of bifurcation, trifurcation, and multiple techniques like T-stenting, mini crush, keloid, decay crush in various settings. So thank you very much.
Thank you.
I think we will go forward to, lecture by Dr. Pratap Kumar. Dr. Pratap Kumar, we can start with your lecture.
I'm trying to share my screen. I don't know. Okay, can you see the slides?
Yes, we can see the slides.
Sorry that I could not connect for a long time. I was struggling. But I'll just go fast to the cases. Actually, my approach to the complex cases. The complex cases means you have anatomy, comorbidity, and equipment actually required in these cases. Basically, the complex PCI is associated with increased risk of mortality and complication at 1 year. So if you go to the LMCA, what actually well shown by Dr. Hiremat in the last few cases, which you have seen, an objective assessment of the lesion, bifurcation or trifurcation or stent sizing is important. You should have a strategy like intravascular imaging, mechanical circulatory support, and you preferably to have a decay crush, and you should have a facility for on-site cardiac surgeon. And always when you do an illustrative thing, calcified lesions, you should actually understand that you have inability to dilate the lesion. stent under expansion, and increased risk of procedural complications. You have a lot of materials available for calcified lesion, starting from cutting balloon to laser therapy. When you go to the impaired left ventricular function, you have higher mortality and the risk of contrast-induced AKI. You have a protected algorithm for mechanical support. I'm not going to details of that. When you have renal insufficiency, you should always look for a grossly guided by invasively measured filling pressures. We have done some zero contrast PCI. That is the way to go about. In a saphenous vein graft disease, distal embolization is a risk. You should be careful in protecting that. A stage revascularization is always important in these cases. CTO, naturally, that is my bread and butter actually. If you have dual angiography, intravascular imaging, and you should always have different techniques you should be in. You should be careful about understanding the complications also. So, antiplatelet therapy should be a lifelong or not. There was a lot of discussion happened earlier in the talk. I'll be just showing some of the cases, which is this patient is actually a cabbage done in 2008. He has angina for 3 years. A TMD is strongly positive, creatinine of 1.8. You have angiogram done in 2016 showed patent graft, SVG to OM occluded, osteoproximal circumflex totally occluded, advised tending to circumflex, but took a second opinion not to come because of the permanent dialysis chance, but never came to us for a PTCA. This is the situation of the previous angiogram in 2018. Totally occluded. There was a tight, significant osteoproximal disease. SVG to OM was occluded. Other graft were patent with a significant angina. Patient had it. Now the patient came with like this. So a totally occluded circumflex artery. We really don't know the distal vessel. So what we tried is actually, we took a filter FC wire, failed. We took an XTR, passed by keeping the previous angiogram as a monitor on the side. We passed the wire down. We tried to pass the balloon, not possible. We tried to pass the tonus, failed. We tried 1.25 rota bar. We just passed the rota wire down through the same anatomy. But 1.25 rota bar also could not cross totally. But with a small burring, we could take a 1.5 into 15 millimeter balloon and a 3 into 18 science expedition stent, and this is the final result. Patient got angina free after a long time. So the raised creatinine is not a contraindication for PCI is the message in this case. This is a case of an inferior MI, recurrent unstable angina, severe LV dysfunction, history of TIA. Patient had LMCA disease with severe triple vessel disease. RCA was CTO, but the territory was not viable. Right internal carotid artery totally occluded, left internal carotid artery 90% disease. So surgeon is actually told surgically high risk. This was the angiogram. LMCA bifurcation. We pre-dilated. We did a balloon inflation. 2 stents. I am not going to details of that. There were 2 stents put. Another stent distally again. Second KBD. 4.5 into. This was the final result of the intervention. This was a result we got from it was a 25% EF patient, but the one carotid artery is totally occluded, other carotid significant disease. We put a protease SC stent. We inflated. During the inflation itself, patient was collapsed, so we did not go for any further dilatation and came out. This was a result. A circulation is maintained there. This was the final result. 3 years post-intervention, symptomatically better, improved ejection fraction from 25 to 40%. So LMCA with a triple vessel disease with a severe LV dysfunction created a barrier for cardiologist, significant carotid disease for cardiac surgeon, but for the patient. Hemodynamic support will definitely make a difference in this case. We clinicians have no right to reject a treatment. This is another case, 45-year-old male, recurrent LV dysfunction failure from 2016 August, evaluated in major hospital, all Investigation told us cardiac MRI report as partially viable myocardium. LV ejection fraction 24%, opted for transplant. A CTO in the RCA, we just wired, put a stent, single stent into the RCA, opened up, circ CTO, balloon dilated, stented. A lady was actually having a significant disease, a long stent 2.75 into 40. Result like this, completed now 4 years, 4 months, ejection fraction improved to 40%, doing business. Heart transplantation is a way for refractory heart failure, but moderate viability, you should give a chance for revascularization. This is a patient of a cabbage, triple vessel disease 8 years back, not going for job for 1 year because all the vessels are occluded, including LMCA, and only vessel patent was a Lima to LED graft. This was the occluded LMCA. We just tried to pass a wire. It is a Conquest Pro 12. Passed. We got a flow down. RCA was totally occluded. We put 2 stents, LMCA to circumflex and circ to the OM. This was the angiogram, totally occluded RCA. We opened up with multiple wires and 3 hours of hard work. I'm not showing to the steps. This was the final result we got from the RCA. So we got all the vessels opened up, including circ and RCA, doing extremely well now. This is actually a patient with a 10-year of class 3 dyspnea, occluded LED from ostium. Patient is having a significant COPD with a ground glass appearance on the lung, occluded LMCA. PCA to LMCA to LED by retrograde injection. We opened up the vessel, doing very well. This is a politician. Actually, these are the cases I wanted to. High creatinine, severe LV systolic dysfunction, diffuse CAD, doubtful distal target, rejected case for both cabbage and bypass. This was angiogram. This angiogram shows a significantly diffused LAD. Distal circumflex is totally occluded, almost not seen. If you go to the RCA, PD and PLV are diffusely diseased. The patient was rejected, significant angina, and LV is bad. What to do first? Explain high risk to the patient, stage stenting to the coronaries, if possible. I told them I can try, plan to do stenting of the circumflex first, see the results, and then plan later. I just passed a CTO of the distal circumflex and the last PDA. I just wanted to OM. I just wanted to open. 7 French GBU, we passed a filled FC wire, 1.25 into 15 balloon, then a 2 millimeter balloon, opened the vessel, then put a 2.5 into 26 DES, opened up, then we saw a lesion in the LMCA to circumflex, we put a 4 into 26 stent. We put a 4.5 into 12 millimeter balloon and finally produced the result only to the circumflex territory, and we stopped there. But the cardiac function improved to 45% and patient wanted to do other blocks so that he was expecting a normal cardiac function. I decided to do it later, but repeated request, I decided to do it. This was the angiogram. You can see a very bad LED distal disease. I was afraid to take even a wire down. The vessel is looking like a 0.5 millimeter distally. I put a wire. You should understand that there is a stent standing from LMCA to circumflex. I put a wire through the strut into the LAD, balloon dilated. That was 1.25. I was afraid it would be perforating or not. 1.5 into 15, gradual dilatation, and then a 2 into 10 millimeter balloon dilated. Then when I was trying to take a stent, definitely it was not able to take the stent down. So what I did is actually, I put a guide liner put up to the ostium of the LAD. This guideline is sitting from the LMCA. There is a stent LMCA to circ is sitting there, earlier stent. So I put a guide liner up to the ostium. Then I have taken the stent down. So the stent is gone down. I put a 2.25 into 40 stent. Subsequently, there was a distal disease. I kept the same guide liner. You can see that I am taking one more stent down through the stent strut and through the 2.25 into 40. Another 36 stent I put distally. So I put a 76 millimeter stent in the lady, and this is the result. I can see there is a significant small disease in the ostium of the LAD, but I just left like that. After 1 year, the patient had a check angiogram, mild chest discomfort, TMT not done, echo cardiac function improved, wanted to have an analysis of the coronary artery. This was the angiogram showing LAD stent are patent. A circ distal is okay, but LMCA to circ, there was a mild stenosis, but ostium of LAD is not very good. But I tried avoiding that. Similar angiogram picture of ostial LAD, so I decided to go on medical management. I did not do anything on that. What happened is actually the similar angiogram picture, the RCA is not bad. Again, it's evaluated after 6 months. Upper epigastric discomfort, clinical improvement seen, echo similar finding, but decided to do an angio with imaging. If significant, I told them I can go for an angioplasty. So this is the angiogram, similar picture, but this time I decided to do an IVUS on the LAD. When I saw the LAD, I was seeing a distal LAD is 3.7, that is actually 2 into 2.3 millimeter, which I put a 2.25 stent. It was well okay. Distal LAD was MLA was 3.7, that is mid LAD is 7.2, and a significant ostial disease. Ostial LAD is only for proximal LAD is 4.2, 2.9, and an ostial LAD is 4.9. So a 2.9 is a very significant disease. So we decided to do something on that. So circ MLA is 5.6 and vessel is 4.5 millimeter. So there is a minimal ISR is also there. So this LMC MLA is 9.9, circ MSA is 4.3, and we decided to do a pre-dilatation, and then we put a stent tap 3.5 into 28 science expedition. We already have a 4 millimeter stent from LMCA to circumflex. So we decided to do balloon dilatation, kissing, then post dilatation with a 3.5 into 12 millimeter distally, then 3.5 balloon to LAD and 4 point balloon to circumflex, and then FKD and a final pot done. We got an area, a significantly opened up area, 7.6 in the ostium, and we got 9.9 was the LMCA, which was become 11.2, ostial LAD 4.2 became 8.2, proximal LAD 2.9 became 7.6, and ostial circumflex and proximal we did not measure, we did not do an IVUS, repeat IVUS. This was the final result we got, and patient is extremely doing very well for the last 1 year. It is now 1.5 years past. This is actually another patient, a 78-year-old man with a significant angina, recurrent admissions in hospitals with recurrent LV failure. The patient is actually, but almost like a normal cardiac function, but at the same time, the patient is having significant angina. This is angiogram, bifurcation disease, CABG is option, but the patient is actually not willing, and this angiogram done 1 year back, similar picture. We decided, we put a 7 French EBU, exchange rota wire. We did a rota. It was a very angulated vessel. We just had a real tough time there because an angulated vessel, we tried initial rota, just pushing. I don't want to get into perforation. It was a really painful situation, just going, and luckily the burr gone down. We did a 2 into 12 millimeter balloon, Maverick, then 2.5 into 12 millimeter, filled FC into the circumflex. Then we actually kept the rota wire there. Keeping the wire in the circumflex, we actually started rota burring from this LAD like this without going back. We burred there. Balloon dilatation, ostium of LAD is not well prepared. So we did a flex storm, 3 into 10. This is the preparation of the lesion. We got a proximal LAD of 4.7. Distal LMC was not good. So finally, we did a flextome of 3.5 into 15 again. 2 flextomes taken, 3 and 3.5. Well prepared, then 3 into 34 resolute and 3.5 balloon there. Finally, 4 into 26 onyx. It's a mini crush technique we use. 4 into 12 and 3 into 12. 4.5 into 8. We got the final result like this. Patient is doing extremely well for the last 4 years. So that we got an 7.6. Final angiogram picture is like this. We got a reasonably excellent result. So the first case was the high creatinine was the problem. Ultra low contrast or residual contrast is the way forward. Second is an LMCA with triple vessel disease and carotid disease. We did both the procedures dying to the 2 sittings. Carotid of the second after 4 weeks. Impella should have been used, but we did not use. Third was a heart transplant was the choice, but luckily we could open all the vessels. Fourth was a multiple CTO with refractory angina. We did this case in 2 sittings. Fifth was a COPD with a ground glass appearance of the right. Lungs, a real challenge for the anesthetist for ventilation, will be a real difficult situation in the postoperative phase. Sixth was the diffuse CAD, still a challenge for many cardiologists and cardiac surgeons. We clinicians should not leave till the last minute and try all chances. Attitude and perseverance of the patient and the relatives still survives and having a good quality of life. Seventh case was patient was not willing for cabbage. We should look for the choice of doing a PTCA if it is life-threatening. Thank you very much for your kind attention.
Thank you very much, Dr. Pratap Kumar. It was a very nice presentation and 7 cases which you have shown are really, very good. I think we'll go to next lecture now.
We'll now move to Netherlands to Dr. Robert Van Joon. Dr. Robert Van Joon is a professor of interventional cardiology at Erasmus University with a special focus on the percutaneous treatment of coronary artery disease. He focuses on complex coronary interventions like left main PCI, chronic focal occlusions, use of left ventricular mechanical support, and the role of intracoronary imaging and physiology in these patients. In 2018, he accepted a position at Radboud UNC in Nijmegen, the Netherlands. He's a member of the program committee at the EuroPCR. He was from 12 to 14, 2012 to 2014. He's author of numerous papers, articles, and he's participated in major trials like the Syntex, Excel, Prospect, Leaders, Resolute, Global Leaders, Absorb 2. Currently, he's a co-PI of the Compare, Absorb, and the IDLE LM trials. He has given multiple invited lectures on coronary interventions at EuroPCR, TCT, and CRT. So I welcome Dr. Robert Van Jones for his talk. The topic is short DAPT post-PCI in HBR patients. Welcome, sir.
Thank you. I hope you can hear me. I hope you can also see the slides this time. There are blocking. This is not.
We can hear you, but we cannot see the
We are
slides.
not able to see the slides.
Yeah, you have to select the other Robert. I can. Please, it's up to you because there are 2 connections.
Earlier we are, but suddenly the connection got lost.
Yeah, I think the host has to. I put this one on transmit. Can you still hear me?
Yeah, we can hear you.
We can hear you.
But you cannot see the slides.
Yes. Also, the video is off.
You can see. Do you see my video? Yeah.
No.
Or you don't?
No video and no slides. Just the audio is working right now. So at the down near to this share start video, there's an option called share.
Yeah, I'm on the shared.
Okay, then just click on the screen, share screen.
Right, that's what I did. And let me switch once more because this is terrible. I shared my screen. I confirmed that one.
So might be it will take 2 minutes. So might be your presentation is pretty much larger. So we can hold for just 5 minutes.
Let me try again, another option. I had network problems with this laptop before. I've not been able to make a connection, so I don't understand why it's blocking it today.
Basangi, I have seen many people hitting sixes in IPL, but Pratap Kumar was one step ahead of IPL. He had 7, which was amazing, Pratap Kumar. And what is Devinder Singh's comment on Pratap Kumar's work? I hope you are happy that you are not in Kochi.
Dr. Robert, I just request you to please unmute your mic. Dr. Robert?
Yeah.
Yeah, okay, now you're audible.
I'm audio, but you don't see any of my screens, is it?
Yep, also the video. Video is also not there.
And that's why I'm logging in on my other computer.
Okay.
And try to see if I can share that screen so that you... that one is blocking as well. That's even worse.
I think he can send the presentation back to you, to the technician, and then he can show it by Google Drive or something.
So I'm working on that only.
It says share content not available. Maybe port 9000 and TCP/80 are blocked. That's one I've never seen before. Let me see how large this file is. It's 18 megabytes. Which one do you want me to send this to?
Dr. Robert, is it possible if you can share us the presentation and we can play it on screen and you can just guide us with the presentation?
Yeah, I'm happy to do that. I'm trying to send it to the invites as an expert for the Cardiology Next. Let's see.
So in the chat section, I have written a mail address. Is it possible if you can share on that mail ID?
Let me do that. Blue Fence Gmail.
Yes, please.
Mahesh, any more presentation left out other than this?
Yeah, there's a last presentation by Dr. Devender. So we can do that. Can we go ahead with that?
I think that is when he is preparing, you can do that.
Yeah, Swapnil.
Yes, sir.
We will go ahead with Dr. Devender's preparation. I mean lecture.
Okay.
Till that
Okay.
time, you can prepare and get it sorted out.
Sure. Sounds good to me. Okay.
Devender, I think we can start. Devender, you have to unmute. Devender. Yeah.
Yeah, good evening, everybody. So, good evening, everybody.
Good evening.
Yes,
Yeah.
we can hear you.
We can
Yeah.
hear you.
So, I'm the odd man out at the end of the day. Dr. Devendra Singh from Baroda Heart Institute. I'm the surgeon among all the cardiologists we have today. And I was party to hearing all the talk about the guide wires and balloons. So, you have a different talk today now, the surgical one. Now, I was told to speak on complex coronary artery disease from the surgeon's viewpoint. So, what exactly is I'm sorry, I'm not able to move my presentation.
Swapnil, can you hear me now? Yeah,
Yes,
okay.
that's fine.
Yes, sir. Just
Okay.
click on this link. Yes.
So, from my viewpoint, complex coronary artery disease is a condition which is not amenable to percutaneous coronary intervention or some form of standard surgical intervention. So, it would include 4 conditions from surgeon's viewpoint: need for reoperative CABG, coronary endarterectomy, patients in whom we find calcified aorta intraoperatively, and the need for myocardial laser revascularization. So I will be talking on these 4 subjects and would be giving my viewpoint on what we can do as a surgeon in these conditions. So complex coronary artery disease is obviously a challenge to the surgeon. So we need to think of different strategies and devise advanced techniques to deal with this particular set of patients. So reoperative CABG or redo CABG as we call in India, the incidence has gone down over a period of years. As we in last 20 years I've seen, we are doing very few redo CABGs now, possibly because of increased use of PCI in post CABG subset of patients, as well as more effective risk factor control, as we've seen from various studies. So most of the times, the mammary to LAD is patent in patients who have undergone CABG about 10 years back. Redo CABG is generally performed because of occlusion of the vein grafts or non-mammary arterial grafts. And in most of the explanted vein grafts, we have seen that there is extensive atherosclerosis more than 10 years after surgery. And the atheromatous disease is very friable, and it can lead to distal embolization when we are doing either PCI or redo CABG. Redo CABG is generally indicated when there is stenosis in the vein graft, which is perfusing large areas of myocardium, mainly LAD, or a patient develops a new distal coronary artery disease which is not perfused by the previous grafts. So this is a situation when we need to do a redo CABG. The key to redo CABG is avoidance of graft injury of the patent grafts. Because perioperative MI, if it happens because of the injury to the patent graft, is a significant predictor of mortality in these patients. So as a part of the planning for redo CABG, we do few studies, of which coronary CT angio is one of the most useful study, because it will give us few guides to the surgical planning. Most important is the anatomy of the mammary arteries, left and right mammary, and how it is related to the sternum, condition of the aorta, subclavian artery, and the patent grafts or patent mammaries, as well as the peripheral atheromatous disease in the femoral or axillary arteries, and the proximity of the heart to the sternum. As you can see in this picture, we can see the sternum here, and in this case, the left mammary artery is about, say, about 1.5 to 2 centimeters lateral to the sternal edge, which is quite safe for re-entry in the redo CABG. In this particular picture, you see that the mammary is lying just below the sternum. So it is at risk of injury when we are doing the redo sternotomy, because the moment you enter or divide the sternum, this vessel is lying posteriorly and is likely to get damaged, which can lead to ischemia and patient can fibrillate. Similarly, you can see in the last picture that there is a right mammary which is crossing over to the left side. A lot of times we harvest bilateral mammaries and we put the right mammary onto the LAD, and left mammary is used to revascularize the obtuse marginal. We have a similar picture here. You can see the right mammary is crossing on from the right to the left, just behind the sternum. And the distance, you can see the CT will give us a guide of how much gap is there between the graft or the aorta and the posterior table of the sternum. In this case, it is about 1.2 centimeter. So it will help in proper planning and avoiding the graft injury. So CT of the thorax or CT angio will actually help us in proper planning and avoiding perioperative complications. So what are the technical challenges when we do redo CABG? Challenge is opening up the sternum again because there is extensive adhesions because of the previous CABG, and there is chances of the heart or the aorta being adherent to the posterior table of the sternum. We need to identify the old graft. We need extensive dissection to identify the old grafts because that will give us a guide to the coronary arteries. Because of the extensive fibrosis, at times we are not able to identify on the surface, on the epicardium, where are the coronary vessels. So it is the old grafts, vein grafts or arterial grafts, which can give us a guide. We actually palpate and feel, and then we are able to reach the target vessel. The presence of graft stenosis itself is a risk because manipulation of the grafts can lead to distal embolization. And at times, because a lot of grafts have been used, if 4 or 5 grafts have been used, there may be paucity of the conduits for doing the CABG. So this is the routine sternotomy being performed. We give a skin incision and divide the xiphisternum and then put in the saw, and we can perform the sternotomy comfortably from below up, then divide the body of sternum, then divide the manubrium. Whereas this changes when we are doing a redo CABG. In redo CABG, we need to use an oscillating saw where we give the skin incision, divide the anterior table of the sternum, and then slowly divide the posterior table, and while leaving these sternal wires intact. So it's basically a bit of more cautious sternotomy. And then in cases of redo CABG, we need to install the cardiopulmonary bypass by doing a femoral cannulation, femoral arterial and femoral venous cannulation. And this is especially needed when the preoperative CT shows us that the right ventricle or the aorta is adherent to the posterior table of the sternum, or there are other grafts crossing the posterior wall of the sternum. So in that case, we need to go on to preoperative before doing the sternotomy. We need to go on to a cardiopulmonary bypass using the peripheral cannulation so that the mediastinal structures tend to fall away from the sternum and we are able to enter safely. So redo CABG OT setup needs following things. We need to prepare. We need an external defibrillator and we need an oscillating saw. At times we need to do a thoracotomy if there are only obtuse marginal grafts. That it is not being done very commonly now because a lot of these patients are undergoing PCI. The sternal wires helps us prevent damage to the mediastinal structures, and it is very important to protect the right ventricle, dissect and isolate the mammary artery graft, and prevent the damage to the innominate vein. It is the diaphragm and the pericardial which helps us identify the epicardium and helps us in safe dissection. Off-pump CABG is obviously helpful because we can avoid clamping the aorta for the cross clamp. So as you can see here in this particular picture, we have done anastomosis on the descending thoracic aorta using a side biting clamp. And then we have already dissected the heart, and we have identified the obtuse marginal, and we have identified the previous graft, and we are going to do a beating heart bypass on this. And this is the octopus device which is going to be placed on the epicardium to stabilize the site of the anastomosis. As you can see here, we have identified the vein graft. Here we're going to utilize the distal end of the vein graft, about 0.5 centimeters, can be utilized to perform the anastomosis. So we orient the graft after marking it so that it is not twisted. And we apply the bulldog on the previous vein graft and utilize a small portion of the distal end of it. As it is not diseased, this graft was diseased proximally. Do a venotomy there, you can see. And the vein is anastomosed to the distal end of the previous graft. And that's the final picture. So in case of redo CABG, we prefer to utilize the in situ arterial grafts, whether it is right mammary or left mammary. It was not, if it was not used previously. And old grafts are generally left in place unless we need it for the distal anastomosis. So distals can be performed on the native coronary artery or distal end of the vein of the arterial graft if it is not diseased. Similarly, proximal anastomosis can also be performed. The outcomes in reoperative CABG as per the STS data shows that the incidence itself has reduced to about 3.4%. Overall mortality is close to about 6%. It is higher in case of elderly and females. Preemptive strategies can minimize the technical and post-operative complications. Perioperative myocardial infarction due to injury to the graft is one of the most important reason for the poor outcomes. And sometimes it may be because of the inadequate myocardial protection, because if the patient goes into ventricular fibrillation. But overall survival is good. 10-year survival is between 55 to 69%. Then the next option we have is coronary endarterectomy. When we find a coronary target vessel is diffusely diseased, there is extensive disease, it's not amenable to a routine coronary bypass. So we need to remove the plaque along with the intima. But most of the decisions are largely taken intraoperatively when we feel that we are not able to pass a 1 millimeter probe also after doing an arteriotomy. Then we decide to go in for an endarterectomy. This requires precise technique and experience because inadequate procedure may lead to perioperative MI and other complications. In this endarterectomy, we basically remove the plaque along with the intima. So there is no endothelial surface. So it is prone to platelet adhesions and thrombus formation. Right coronary artery is the most common vessel on which endarterectomy is done. LAD is technically more complex because of the septals and diagonals arising in different angles. And the atheromatous core of the LAD is narrow and delicate. It can disrupt and shear off from the vessel. So we might have to extend the arteriotomies to complete the endarterectomy. Most of the times what we do is we apply a onlay vein patch because the endarterectomy lengths vary from 5 to 10 centimeters. So we might have to put in a long onlay vein patch. On top of that, in middle of the vein patch, we put in the mammary artery grafts. So for doing endarterectomy, we initially try to put in 1 millimeter probe. If it doesn't pass into the vessel, then we extend the arteriotomy to about 2 to 3 centimeters. And then we use the endarterectomy spatula to delineate the plane of dissection. And then again, probe is put in to break the adhesions. Traction and countertraction is given. Traction is given you holding the plaque, and countertraction is given on the epicardial surface. Once the complete endarterectomy specimen is removed, then we apply, we put in heparinized flush and vein onlay patch is applied. Most of these patients are put on perioperative heparin infusion, and these patients have to be put on lifelong dwell antiplatelets. So this is how what I was telling is how the endarterectomy is done. This is a pictorial representation of things. This is one of our patients where we have done LAD endarterectomy. As you can see here, traction is given using holding the plaque, and countertraction is given on the epicardial surface. And this is from the LAD, and this one is from the diagonal. and we are putting in 1 millimeter probe to separate the dense adhesions from the media. So at times, if we are not able to complete, we might have to extend this or make a second incision distally to clear off the plaque completely. So coronary endarterectomy outcomes, the mortality is close to about 3%. Risk of perioperative MI is there in about 5 to 10% of the patients, especially when endarterectomy is incomplete. But the survivals are good. There is about 64% survival at 5 years and 36% at 10 years. And now the third condition we encounter is calcified aorta. If the ascending aorta is calcified, atheromatous, then we may have to change the surgical planning. So it is a technical challenge for us because manipulating the calcified aorta may lead to cerebral or systemic embolization, and the degree of the calcification may vary from isolated plaque to completely calcified ascending aorta, which is called as porcelain aorta. So we need to avoid the aortic manipulation. So a manipulation can be either partial or completely avoidance. And in case of calcified aorta, the stroke risk is close to about 10.5%, whereas the stroke risk in a standard CABG in a non-calcified aorta is less than 2%. So how do we diagnose this and how do we proceed? So routinely, if there is suspicion of calcification of aorta on the basis of extensive peripheral vascular disease or on the basis of the risk factors, we can actually perform the preoperative CT thorax to look for the calcification ascending aorta, as well as intraoperatively or routinely, surgeons do a manual palpation of the aorta where we can feel the plaques in the ascending aorta, and it can be confirmed with the epiaortic scanning or transesophageal echo if you're using it routinely in your surgical practice. But the chances of having the calcified aorta increases in patients who have got peripheral vasculopathy, diabetics, and dyslipidemia, and of course, an advanced age, more than 70 years of age. Preoperative X-ray also sometimes shows the calcification. Epiaortic scanning is very good because it identifies the soft plaques as well as the thickened areas, and it can help us avoiding those sites for calcification or cross clamping or side biting a clamp. So obviously, it helps in reducing the incidence of these strokes. So these are some of the pictures that shows the calcified plaques you can see in the ascending aorta here also. And we get these good pictures and then we can avoid those sites. So what do we do if we have a calcified aorta? So as a surgeon in India, we are largely practicing off-pump CABG. So that is I would say one of the best options. You can perform the multiple arterial bypasses using various combinations. So these are the various combinations we use. We can use left internal mammary artery to the LAD, right internal mammary artery to RC or PDA, or we can use the right internal mammary artery to the LAD. It will cross over to the left side, and the left internal mammary artery is done to the obtuse margin. And the combination which I commonly use is left internal mammary artery to the LAD, and I do a Lima radial graft, and this Y graft can be used to anastomose the obtuse marginal as well as the PDA. So in this way, we can complete the revascularization. So this is the routine off-pump CABG. Just the picture here for the cardiologist colleagues to just see. This is the anastomosis of mammary to LAD using the octopus device. We're just stabilizing a portion of the ventricle so that it can be used to bypass the mammary to the LAD. And this is LAD in mid portion. You can see the proximal end is here. This is the head end of the patient. That's the foot end of the patient. So it can be comfortably done unless the LV is very poor and a patient is unstable. Similarly, anastomosis to the right coronary artery. And this is octopus device applied to the inferior surface of the ventricle. As you can see here, we dissect and then go ahead with the anastomosis. Arteriotomy being done. As you can see, the rest of the ventricle is contracting nicely. Only this particular portion is stabilized and with the octopus device. And we're putting in a shunt to prevent ischemia, distal ischemia here. Similarly, the lateral wall the OM grafts can be tackled. Mammary to LED is already running now, and we have a starfish device that elevates the heart, put it upside down so that we can expose the lateral surface and the vessels close to the AV groove. As you can see here, I've done the second obtuse marginal branch, and we can put a Lima radial Y graft to this. So there is another option of no-touch technique in surgeons who are practicing CABG on cardiopulmonary bypass. So here we can do put the patient on cardiopulmonary bypass using the femoral artery, femoral vein, and we can do the CABGs on fibrillatory arrest. Internal mammary artery can be used, bilateral mammary can be used, or Lima radial Y graft can be done to avoid clamping the aorta. This is another one from my practice. As you can see here, mammary is anastomosed to the LED to revasculate the LED, and the radial artery graft. So this is Lima radial Y graft, and this is used to anastomose to the diagonal as well as the obtuse marginal. So this increases the scope or for the revascularization in patients who have got a bad aorta. And we've just received a new device from Europe, from France. And this is called as enclosed to device. This can be used in patients who have got calcified aorta. So we do aortic scanning and identify the spots which are disease-free. And then we can insert this device. You can see this device. This device is like a clamp. There is a top portion which is used to compress onto the anterior wall of the aorta. And there is a bottom portion actually, which is actually a diaphragm to prevent bleeding from the aorta. This is the operative picture. Can you see in our patients? We can see we made an aortotomy here, opening here. And there is a diaphragm below, which is preventing the blood leaking back from the aorta. And we have made an aortotomy, and we can safely do the proximal anastomosis on the aorta. Besides calcified aorta, I am using this device to do the proximal anastomosis in patients who have got extensive carotid artery disease as well, which is not amenable to surgical correction. So to prevent perioperative stroke. So we always promote total arterial revascularization, but the incidence has been terribly low all over the world. In US, it is close to about 10% something, and Europe, the incidence is about close to about 20%. Why is the incidence of total arterial revascularization low? Because bilateral IMA harvesting is technically more demanding. It takes longer time to do. It makes a simpler operation more complicated. And few surgeons on few studies have shown that increases the risk of wound complication. STS data shows that the current second incidence of the arterial graft is less than 7% in US, whereas the incidence in Europe is about close to about 20%. So outcomes are good, especially in OPCAPs. There are lesser neurological and renal complication. There has always been doubt whether we can perform complete revascularization in off-pump CABG, but I think we've done, and on average 4 to 5 grafts in most of the CABGs. The ICU stay is shorter, the mortality is less than 2%. Whereas no-touch technique, because then we are doing cannulating the femoral artery, there is still some risk of systemic embolization and neurological and renal complication. Stroke rate is still 2.3%, mortality is 2.8%. The last topic is transmyocardial revascularization. I myself, I was personally involved in this particular method of, I would say, revascularization or an adjunct method. It is indicated in patients who are in NYHA class 3-4 severe angina, which is refractory to medical management, in patients who have coronary artery disease that is not amenable to revascularization. But it is contraindicated if ejection is less than 20% or if there is possibility of revascularization. Angiogenesis is induced by laser, that is YAG laser or CO2 laser. It decreases the severity of angina as compared to medical therapy, and this decrease in the severity lasts for almost up to 5 years, and this can be used in conjunction with CABG. As you can see here, we have done the pericardiotomy. We have opened the pericardium. And this is the probe which is applied on the surface of the ventricle. And we start from the basal portion from the inferior and we come to anterior. And the energy is applied at 1 centimeter distance and in the area where the grafting is not possible. And we've used it mostly in conjunction with CABG. And this leads to some bleeding, and which can be tackled by applying dry gauze piece and compressing the area. You can see those areas which are basically which have been where we have applied the laser. TMR is provided through handpiece that delivers the energy to epicardium, and it is mostly YAG laser, and it is synchronized with R wave on the ECG. 20 to 30 joules energy is given as 4 pulses per second. And we generally create 1 mm channels in the myocardium, which can be seen on transesophageal echo. But it is not applied to the scarred area because that may not benefit. Mortality in TMR is 1 to 5%. Survival rate is about 76 to 96% at 1 year. And there is a definite reduction in angina class by 2 or more in close to about 25 to 76% patient, depending on various studies, what data we have. And there was a Cochrane analysis done in 2009 of 1,200 patients, which showed that there was insufficient evidence of the clinical benefit of this particular modality. But still, I would say a few more studies have shown that there are excellent perioperative survival and patients are less symptomatic at the follow-up. So I would still say that it's applicable to select group of patients with severe angina due to diffuse disease as an addition to revascularization. So we can perform CABG, and those areas where nothing is possible, it is not possible to bypass the vessel, we can do a TMR and help the patient. So concluding my talk, I would say, I'm sorry. To conclude, I would say complex coronary disease is a challenge to the patient, to the surgeons. We need to evolve different strategies and utilize newer techniques. Reoperative CABG carries a high risk, but we can minimize the perioperative complications using proper assessment and surgical planning. And in patients with diffusely diseased vessels, we can offer them coronary endarterectomy. And in case of extensively calcified aorta, off-pump CABG or no-touch technique can be offered. And if we've exhausted all non-surgical options, TMR can be offered in select group of patients. Overall, if you see in complex CAD, the outcomes are improving and the results are safe, and these procedures are effective. I would suggest that all the surgeons and obviously my the cardiology colleagues should also familiarize with these procedures so that we know that we can offer these to our patients in a particular subset of patients. Thank you.
Thank you, Dr. Devendra. It was a very nice presentation as far as complex coronary disease surgeon's perspective. Thank you very much.
Thank you, sir.
Swapnil?
Yes, yes, sir. I am working on it.
Yeah. So
I request
can we go ahead?
can you please? Yeah.
We have some time, or?
So hope you can see the presentation.
Yes, yes, we can see the slides.
Yeah, Dr. Robert, over to you.
Thank you. I hope you can all hear me now, and
yes, yes.
also see the slides. I'm sorry, I still didn't understand why my laptop doesn't want to use the WebEx to transmit. But anyhow, let's try to do this presentation, and I hope that you still enjoy it after this long way. So I'm going to talk about monotherapy for platelet inhibition. It's a little bit close to the high-risk bleeding patients we discussed earlier in this afternoon. And let's go to the next slide. I have two topics I want to discuss. That's on the next. So when are we going to step down from two platelets inhibition medications, and which one are we going to stop? If we discuss stopping one, either the P2Y12 or the aspirin. Next slide. So then you have to go over to the go through all the guidelines, the sections. Remember that we have 70 pages in this table, the chronic coronary syndromes, and 79 pages in the non-STEMI patients in the European guidelines. Lucky enough, the section on platelet inhibitions are a bit shorter, and lucky only 2 pages on this topic I have. Go next. So, as discussed earlier today, it's all a balance between the ischemic risk and the bleeding risk for each individual patient. And the characteristics, either patient characteristics, you have clinical presentations, you have the comorbidities, which are patient related, but you also have procedural aspects in the yellow ones to the right, either the PCI, and then if you do a PCI, is that a straightforward one vessel, or as we have seen today earlier, left main with 2 bifurcations or multiple CTOs in patients? And then all in between, you also for the patient co-medications. I won't talk long except on the oral anticoagulations for this section. Go next. So you can see the therapies we have been giving over all these years: the ticlopidine, the clopidogrel, and then later on the Ticagrel and the Ticagrel, and multiple studies showing all their durations: 1 month, 3 months, 6 months, 12 months, and even in Pegasus and DESLATE or depth study over 30 months. Go next. So based on the CURE study, I think then you can see that's 2001, and all these 19 years, I think 12 months DAPT duration has been the standard, and is most frequently prescribed for our patients after PCI. Go next. But based on more modern stents, and here are 2 studies either been doing with a Zatarol stent, looked at shorter DAPT durations for either 3 months or 6 months, and go for the results. Click. So this was a study from Korea and one from Brazil. Next slide. There are some animations in it. So that's the primary endpoint. And you can see that the primary endpoint either is non-inferiority for the ischemic endpoint and usually superiority for the bleeding endpoint. Next. But these 2 studies both demonstrated that usually there's no difference in the primary ischemic endpoint, and sometimes some advantage in the bleeding endpoint. Next slide. So these are I would say the largest and most frequently studied RCTs: excellent, reset, optimize, these are safe, security. And then italics and quality, they are complex because they originally were on a control group of 24 months DAPT, but for this meta-analysis by Navarrete, he used the 12 months data from these 2 studies and give you the overview. Next slide. So these are on 2 subjects, on 2 points. You can see it's on the ischemic endpoints and the bleeding endpoints, which are on the lower right, where you can see that you have less bleeding if you have the total of all these studies done over 8,000 patients in short-term antiplatelets, or 12 months as the control group. There's a significant reduction in the bleeding, and but all things for the cardiovascular mortality, the myocardial infarction, or the stent thrombosis, which is the upper graph to the right. It's all no difference. So the odds ratios are close to 1. Next slide. Next. So these are 2 in 1. So just wanted to focus on the newest update from the TCT Connect this year. And that was a focus section, a focus study on high bleeding risk patients with a science stand. And they had 2 potential regimes. It's either 28 days or 3 months, the 90 days. And that was depending on their high ischemic bleeding rates, high ischemic bleeding risk. And that will be compared to historical data from the science studies in the US. Go next. Primary endpoint, first of all, again, was the safety, all death or myocardial infarction under shorter DEPT regimes. And then the secondary endpoints were to determine the impact of the short DEPT versus the traditional depth of 12 months on clinical relevant bleedings, BARC 2 to 5, and also have to see if stent thrombosis was influenced or not. For that part, you have to realize that it is a little bit more underpowered, so that's why that is not a formal a powered endpoint. Next one. Go. Next, yeah. So you can see here the mean rates for the non-inferiority, and this is the all death and MI slide. So this definitely, you can see the non-inferiority margin was set to 2.8%, and the events were really close to 0. So there is no difference to the historical group, 0% difference, which is well within the limits of the non-inferiority margins. So also for the science stand, it has now been demonstrated. This is the 90, the period from 3 months to 12 months. And you see, if you stop the medications, there's no increased risk of death or MI. Next slide. Next. There's also an analysis from 1 to 6 months. That's for the patients who had only 28 days of therapy, death or MI in that section. And again, next slide. There comes the non-inferiority margin. You can see how this is. You can see the current times 28 days, which is 3.5% versus the 4.3% in the historical Science 5 US data, which is propensity matched to be sure that the patients are as much similar in each group. No significant difference between these two. Next. And this is then the powered secondary endpoint for the bleeding. As expected, if you reduce the antiplatelet therapy, you will see that there is a reduction. This is statistical, not significant. It's 0.06. 687 and 0. Next one, 0.19 on the next slide for the science 28, where there was the bleedings between 1 and 6 months. That's on this one. And then just to share with you also the secondary endpoint. We cannot see the full slide, so something happened to the colors. I'm not sure if you see it correctly. There it is. So the performance goal was 1.2% from historical data, and in the science, which we had short from 90 days on, so both groups were off the APT, you can see only 0.2% stent thrombosis rates, which is really low, but that confirms the safety of the latest generation DES we have in this current settings of PCI. Next slide. So after discussing and updating you on shortening the DAPT period, you can see that we frequently can stop the DPT at 6 months. If you have a high risk bleeding patient, you can either stop at 1 month or 3 months, and still seems to be safe to stop the DPT. In this case, the clopidogrel frequently after that period. But the other context is the ischemic risk patients. And if we look at the Pegasus study, which was studying prolonged DPT, you can see the endpoint. Let me show a little bit. There's no text in this slide. Can you forward once more? Yeah, and next. Yeah, so this shows the inclusion of these kind of patients. So these are the kind of different patients. They don't have an extremely high risk bleeding risk, but they have a history of previous MI and then an additional risk factor for ischemia, being either above 65, either having diabetes, second MI, multivessel disease, creatinine clearance below 60 of peripheral vascular disease are all enrichments for high ischemic risk. If you continue these patients after their initial 12 months for their older infarctions, you can see that there is with Ticagrel, even over these 36 months, an important reduction in ischemic endpoint, although, of course, as expected, some increased risk of having a bleeding event. Next one. There's another one study, I think all familiar to you, the DPT study, which continued to use of DPT after the standard 12 months, as it has been for many years. So patients were randomized at 12 months if they have been event-free, that means no bleeding in the first 12 months. And they were randomized for another 18 months of clopidogrel or a placebo on the background of an aspirin therapy. Again, you see the effects on stent thrombosis on the left side and the total major adverse cardiac events to the right side, with a significant reduction using prolonged DPT in high ischemic risk patients. Next one. So conclusion is that we have several options, either shortening DPT or prolonging DPT. And that means that there's no single DPT strategy for all, although 6 or 12 months may be a baseline therapy, but you have to make a tailor-made therapy for all patients. Next one. And that was a bit discussed earlier today. It's either things we have to look at is on the PCI itself. So you can look at complex procedures. We have seen a lot of them today, more than 2 vessels treated, more than 2 stents implanted. That was published in 2016. And you can see that they favor of having a prolonged therapy or up to 12 months, I have to say correctly. These kind of patients potentially, although there is some interaction and some reduction in events, 5% reduction, but still an overlap with the hazard ratio of 1. But the higher the number of complex items during the PCI seems to be favorable, not stopping the DPT at either 3 months or 6 months. On the left side, you can see these kind of 2 different therapies. Next slide. Go. Next, so we can see the full slide. The depth score, which is then one of the scoring systems used to either select high bleeding risk patients or high ischemic risk patients. But realizing this table from the study, from the depth study investigators, really interesting to see that quite some things are happening on both sides. So it's peripheral artery disease, which is the one which gives both an increased ischemic risk and a bleeding risk, like renal insufficiency, also increasing ischemic risk and bleeding risk. Next one. So they use their hazard ratio to give the calculations and give an advice if you want to continue over 12 months in the direction of 13 months or 36 months, realizing that patients above 75 have negative points because they have increased risk for the bleeding, as you have seen in the previous slide. Now you can see all these points, and I think you're pretty much familiar with them. So I'd like to continue to the next slide, where you can see the outcome. You can see that if they have a depth score 3 or more or 2 or more, gives a significant reduction if they were on the 30 months therapy. No, yeah, this one still correct. And the bleeding risk were mainly in the patients who had these negative DPT score, so above 75 years. You can see that they had increased bleeding risk, potentially without having a lot of benefits from their ischemic risk reduction. Next one. Precise depth was another method to try to combine all these risk factors. Like age has a hazard ratio which goes up. And this was a little bit easier one because it had a lot of less parameters to look at. So age, previous bleeding, white blood counts on admission, hemoglobin on admission, and creatinine clearance, also known at the moment of procedure. And you can see that the bleeding risks goes up the higher your score is. Let's look at one which I always previously want to discuss with you or show as clear as possible. That previous bleeding already gave you above 25 points. And if you have worked with the precise depth score before, you know that that score above 25 is going to give you an increased bleeding risk, and this pretty frequently used cutoff point trying to reduce your DPT duration. Next one. So this was shown earlier today, so I think I'm going to skip you. This is as the ARC definitions has been incorporated by the European Society on Bleeding Risk with either one major or two minor, which is, you have just seen the discussion on how this has been calculated. It's pretty a long list of things you have to try to remember, both major and then have to remember all minor ones as well. So I'm still not really happy, and I don't think it's really practical always to look at this list for these patients, because it's also bleeding risk, but some of these patients also have a high ischemic risk. Let's continue. So this is the ESC guidelines from 2017, and you have to see on the left it's a stable coronary artery disease, and to the right is acute coronary syndrome, where you can see both the standard or the reduced platelet inhibition period. So it's advised in the stable angina, you can choose either for the 1 and the 3 months therapies if you have patients with high bleeding risk. For the acute coronary syndrome, you're reducing from 12 to 6 months. Next slide. Which has not changed dramatically in the later versions of the 2020 guidelines. I will discuss a simple approach in the end. Here you can see and also realize that the prolonged DPT periods are usually on a class 2 A or B, mainly a B recommendation. I want to take some of your time still to discuss the next few studies. Next slide. And I didn't discuss a lot of the oral anticoagulation therapy schedules, which are even more complex. But I wanted to show you some of the, I would say, more recent, although global leaders already back in 2018, which was then changing over. So shorten the EPT duration by stopping the aspirin and go, in this case, for ticagrel monotherapy. You might be familiar with the design because it was a complex design. Patients on the experimental arm were all on ticagrelor. In the reference therapy, it was more complex because the patients in the ACS group were on ticagrelor for 12 months, which is shorter than the experimental arm, and the stable angina period patients were on clopidogrel for the first 12 months, which was less intensive therapy compared to the experimental arm. But it was a very powerful study based on the high number of patients, 16,000 patients in the study, and very hard endpoints, all-cause mortality, and Q-wave MRIs on an ECG at 2 years follow-up by the core lab analysis. So that were hard endpoints. The bleedings were investigator reported, which was not a part of the primary endpoint because investigator reported endpoints are not that hard as an CAC or core lab reported endpoints. Next slide. But the signals were pretty interesting because the experimental arm with ticagrelor monotherapy without aspirin was reducing bleeding. You can see that on the right in the first year. In the latter part, in the next year, you can see that the therapies are more equal to each other. There was ticagrelor monotherapy versus aspirin monotherapy. Yeah, of course, you will have some more bleeding than at that period. The primary endpoint was also interesting because there was a real, we can't say a statistical significant effect, but there was an interesting reduction of lower numbers. I cannot say there is a reduction, but you can see the 3.8 for all-cause mortality and MI versus 4.37 was giving the evidence that the ticagrelor monotherapy might be superior without increasing the risk of having more bleedings. Now, that was a mixed, complex design study. The next one, please. Next slide. Because this was the stop depth study, which was much easier to follow because in the stop depth study, that was the aim was to go for clopidogrel monotherapy with aspirin therapy only for 1 month. You have to realize these patients were somewhat more selected for low-risk patients. But of course, now there is, in this size, you cannot look at there was not sufficiently power, I would say, to have primary endpoint pure on ischemic endpoints, but there was a reduction in bleeding endpoints, and the combination, the netto, it mainly driven, the netto adverse cardiac event was lower compared to continuing the DAPT for 12 months. Next one. A bit similar. The smart choice, in this case, aspirin was only for 3 months, and then clopidogrel monotherapy was continued. The primary endpoint, MACE without bleeding, was similar in both groups, and there was a trend, no significant effect on bleeding bar 225 in this period. Next slide. And then the largest trial of all on the next slide, the Twilight, probably also familiar to most of you. In this case, again, ticagrelor monotherapy versus DAPT, ticagrelor with aspirin, 12 months, clinical bleeding in patients, and continue on the next slide. Again, an enriched population with some more ischemic risk and also more bleeding risk ratios. Next slide. I hope that you don't have a problem with continuing for the slides. Forward. Yeah, next. So this is the study design. Again, the patients had an enrollment period, randomization period, where they had ticagrelor, aspirin, and ticagrelor monotherapy, and an observation period after the experimental habit. Up to 3 months, they all had the same therapy. After 3 months, the aspirin was stopped, and either aspirin or placebo was given. Next one. That's back. Next, forward. So the primary endpoint for bleeding was highly statistical significant with an hazard ratio of 0.56, so almost a 50% reduction of your bleeding endpoints. Next. And on the safety, the secondary endpoint, no statistical difference was seen. Non-inferiority was met in these graphs and in these conclusions. Next. But realize most of these studies are sometimes complex. We always have to look at this either a combined, the major adverse cardiac events, or the combined with the netto effect. Sometimes mixed durations, 3 months, 6 months, 12 months, 24 months. Some studies also have a mix of DAPT, either clopidogrel with prasugrel and ticagrel in one arm, so you can never make firm conclusions. And usually previous selected patients either being low risk for short DAPT or either being high risk for bleeding, specified on high risk bleeding patient studies. Next one. So just showing some more of the potentials we have. What happened after Twilight and Global Leaders? We can show you that ticagrel monotherapy is now in the guidelines as a 2A indication after 3 months. And you can see that, yeah, it's difficult to make a decision if you want to be in the ticagrel monotherapy or the aspirin, and then potentially prolonged therapy if the patient has multiple ischemic risk factors. Continue. So, looking at several issues, these are, I think, the most frequently and the most impactful risk factors. You can put them in two classes: a high bleeding risk. It's a short version of the most recently used ARC1 in the European Society of Cardiology guidelines. This is what I try to bring in to our young doctors doing on-calls in the weekends and seeing patients, giving the first therapies. This is what I want them to remember. All of them, that you may know them by heart. Telling you. So there's indications for oral anticoagulation, a previous intracranial bleeding or spontaneous bleed in the last 12 months, or severe kidney failure, renal failures, severe anemia. And then we have the long-term high-risk ischemic patients or the diabetic patients, second ACS, multivessel disease. The somewhat reduction in renal function. They also have an ischemic risk and peripheral artery disease. Next one. So if you want to try to put that in either one or two classifications, where you try to put these guidelines, 70 patients, 79 patients, in a little bit simplistic fashion, then we keep it like that. We have on the left side, elective PCI for stable angina, they will go for standard therapy 6 months. And they might, if they are high risk bleeding, and we summarize that to the 4 risk factors below. And of course, if the patient has a known malignancy, has a known severe liver function, people also realize that that would increase bleeding as well. And you have to look in your guidelines to find which are the correct cutoff values to select these kind of patients. But these are the most frequent ones: the previous intracranial hemorrhage, spontaneous bleeds. We will reduce them one step down from 6 to 3 months clopidogrel. I showed you the graph why we included in our region some patients for 12 months, and that's in the period that we still believe that the stents has to be covered. These were excluded from most of the studies on shorter DAPT, so CTO, 2-stent bifurcation, more than 60 millimeter stent of an SVG treatment. For the ACS patients, we also have a pretty simplistic approach. Standard therapy is 12 months, it's ticagrel, and then again we have high-risk bleedings, which are then shortened from 6 to 12, and we have high ischemic risk patients, as in Pegasus or in depth studies, and these patients are ACS, and then have another ACS or another reason for high ischemic risk events, as listed above. we won't do that for patients above 75 years because we have seen that from the meta-analysis done in Europe, where we have multiple studies put together, and you have the 2 points in the depth study. These are potentially patients who are not suitable for 36 months. And then on the next one, next slide, we have us. That's 2. Go back 1. That's on the patients who have an indication for NOAC or NOAC, but the approach is a bit the same. We reduce from standard for high-risk bleeding 1 step from 6 to 3, or from 12 to 6. And we in the NOACs, I didn't have to discuss that with you, but you will see that the aspirin is dropped much earlier, either 1 week or 1 month, as long as maximum therapy period for the aspirin, besides the oral anticoagulation or the NOAC which the patient was using previous to the treatment. And that's on the, I would say, go back for, thank you for your attention on my last slide, where we try to simplify. I think the main message is that from the 12-month standard therapy, we have gone back to 6 months from stable angina. Next slide, please. Next. So 6 months standard therapy for stable angina, chronic coronary syndrome, or 12 months acute coronary syndrome. Both have one reason to step down, 6 or 3. And we have something complex and high ischemic risk patient who have potentially of long, prolonged DAPT. Realize that always high risk bleeding is the first one. So if the patient has criteria for the high risk bleeding, he will never have prolonged DAPT. We have seen sufficient evidence from multiple different current generation drug-eluting stents that they all allow reduction, and you have seen the latest update on the side stent. This large study from Roxanne showing that in principle, I believe all current generation DES have the availability of doing these reduced DAPT strategies. Thank you for your attention.
Thank you, Dr. Robert. I think this has been an excellent presentation. This is the usual problems that we face, the dilemma that we face in our day-to-day practice as to when to stop, when to reduce the depth, especially in patients who have had a recent PCI or multivessel angioplasties. So this has been very informative, and we thank you for that. We could take a few questions at this point. Any questions?
I just wanted to try to, if there's no question yet, I just wanted to discuss.
Yes, go ahead. Dr. Sharma, go ahead.
Yes, Dr. Krishnan.
Unmute.
Okay.
Dr. Bhupesh, yes.
I think just I want to ask about the Selatogrel. What is the future of Selatogrel? Injectable Selatogrel.
Dr. Robert?
Yeah.
Did you hear the question? Injectable Selatogrel?
Not precise.
Yeah.
So, of course, we have seen, to make everything more complex, patients who have not a traditional indication for oral anticoagulation, so we'll combine an clopidogrel with a NOAC in the patients without atrial fibrillation. The COMPASS study was one there. Still, these studies are less in number. And I think that we have sufficient evidence that we, for the moment, work on the antiplatelets. So we've totally focused on antiplatelets, I would say, in the patient without an indication for antiplatelets due to their atrial fibrillation.
Yes, Dr. Sharma.
Yeah. Are you audible? I am audible to you?
No.
Bit more louder.
Speak louder.
Yeah. Any Prasugrel monotherapies? Any experience?
Dr. Robert, did you hear the question?
No, definitely not.
Dr. Krishnakant, you can speak louder. Remove the mask.
Any experience with Prasugrel only monotherapy, if aspirin allergy or something like that, or 5 or 10 milligram with Prasugrel only?
Dr. Krishnakant, your voice is, can you please remove the mask slightly and ask, please?
I think I can hear you slightly. The Prasugrel monotherapy has hardly been studied. So that's why it's not in our schedule. We have, of course, seen ESAR React, which was really, ESAR4, which was really astonishing, I would say, comparing the Prasugrel versus the Ticagrel in the post-ACS patients, was in favor of being on Prasugrel. So there might be a real nice potential to look for Prasugrel monotherapy, but I'm not aware of sufficiently large studies with Prasugrel monotherapy to bring that up as a current therapy. I think they will be there in the next few years, yes.
Thank you, sir.
I think there are no more questions. I think we'll close the session. Thank you, Dr. Robert. Thank you very much for joining us at Cardiology Next and making a presentation. We have enjoyed it a lot, and we wish you a very good evening at Netherlands. To all my colleagues in India, a very good night. I thank all the speakers in today's session in Cardiology Next who have been very lucid, very informative in their presentations and has given us a lot of information, evidence-based treatment protocols. And I thank all the panelists also who have been spending this Sunday evening with us. So thank you all. Have a great night. We'll meet again in our next session of Cardiology Next.
Thank you and goodbye.
Goodbye.
Thank you.
Thank you. Bye-bye.
आवाज क्यों बता दो भाई तुम्हारा और नहीं तो बराबर बोलते लाउडली देता हूँ एक्चुअली
Sir, you are live now. Please switch off the mic.